What I get this year.
That's not the goal.
Good afternoon, everybody. Good afternoon, everybody. Welcome to the Research Symposium. I'm Jed Gonzalez, Senior Associate Dean for Medical Education. Dean Lehrman is away. He's representing us at a national conference. He asked me to fill in for him. He extends his wishes that he was here. This is the first time he's missing, so he feels pretty sad about it. But welcome to a great opportunity for us to be celebrating, acknowledging our students, our teams, our mentors in such great work that our students have done. This comes in a flurry of experiences and activities for the School of Medicine that is just a great sequence of events. Last week, we had the Gold Humanism Honor Society induction. 7 to 8 of our students inducted with residents and fellows and faculty, and Dr. Jacqueline Nunziato giving a remarkable speech. We had a match day, 100% match rate, awesome programs. Yeah, it really is a remarkable thing. We're very proud of our students and all the educators that helped them along their way, the mentors. And we got the Research Symposium right here. And then we have graduation coming up. It's coming up pretty soon, everybody, with a lot of activity coming up in the next 2 months. So it's nestled in this great celebratory time. This is our 11th Research Symposium. First one, March 24th of 2014. Dr. LeConte and Dr. Friedlander are here at perfect attendance. This is perfect attendance, is that right? Anybody else have perfect attendance to the Research Symposium? So maybe Mike and Leslie can give us their insights all the way back to, Leslie reminded me today that she made the program in 2014, all the way back. So it's really great to see this program thriving and moving forward in such a strong way. So I want to just give one comment on where this fits into our scheme for the medical education mission here at VTCSOM. This comes from last year's strategic planning process about what's our North Star for the medical school. Certainly we care about patient-centered physician. That's an indisputable piece. But surrounding and synergizing with that patient-centered physician are the identities that we really hope our learners, when they leave, that they're carrying forward into clinical care and with patients. The Master Adaptive Lifelong Learner, we know that we cannot know all the information that we need. It's a commitment to a lifelong journey of developing our skills, identifying our gaps, reflective practice. That's what we hope for our learners. The system citizen, the systems thinking physician who says, we need to see the holistic picture for our patients, clinics, health system, the social determinants of health, high value, cost conscious care, quality improvement. And in the bottom right is the scientist physician. And that's what this research symposium is all about. This has been our genotype. It is our brand. It is our differentiator for VTCSOM. It's a remarkable thing. A lot of the skills that we hope for our learners as you see these projects, these posters are awesome. These oral presentations we're going to hear are fantastic. What we dream of is these skills transferring into clinical practice with patients in just several months as interns, residents, and as faculty. It's also a great opportunity to really thank the people who make this happen. This is our snapshots of all of our mentors who have worked with our students. These are not projects that necessarily last 2 months. I mean, this is a 4-year commitment by our mentors. So take a peek at all these pictures. Many of them, I see several in the room. And it's a great opportunity to be thanking them. Our mentors come from many different facets. Of course, FBRI has been the mainstay of mentorship since the start of the school. VTC Clinic faculty, there's a number of them on this list, certainly several in the crowd. Virginia Tech, we have great diversity, and also outside of those three, that tripod, Dr. Friedlander works really hard on outside mentorship. So it's really a great opportunity for us to be thanking all of our mentors, all of their teams, and acknowledging the diversity of projects and teams that come together to actually allow this program to flourish and be as great as it is. I want to thank Dr. Friedlander. Dr. Friedlander is a remarkable support for the School of Medicine and our medical student education and his commitment to making sure that these programs like this exist and survive, and the research team. Imagine we have about 200 students at VTCSOM. These projects are not just by 1 year, they're across 4 years. So there's a ton of coordination that is required to pull this off. And I just want to acknowledge the research team, Crystal Barnett, Kara Spivey, Jessica Flowers, Leslie LeConte, and Nikki Worthington. If you see them today, please extend thank yous to them for everything that they do. So looking forward to hearing the students' presentations, and I'll pass it off to Dr. Friedlander. Well done.
Just leave that up there. Just leave it up.
Thank you, Dr. Gonzalez. So welcome, everybody. It is a pleasure. I'd lost track of the years. I guess it's the 11th time we've done this, but it's always exciting to me personally. And I just want to comment on the slide Dr. Gonzalez put up in the lower right corner, which said scientists, physicians. I know that's who I want for my doctor and my family doctor. So we want you. We want outstanding physicians who have trained here, who take a scientific approach, as well as the broader holistic and humanistic approach as well. Some of you will go on to be, most of you probably, practitioners of medicine, but we hope you will carry with you that scientific view, and that what you've been involved with in research will drive you and inspire you on behalf of your patients. Others of you may continue on and be active in research, whether you're in private practice, academic medical center, et cetera. And for those of you who do that, you will have the privilege of impacting the lives of generations to come, in addition to the patients that you're working with today. And so I always think that's a wonderfully admirable role to play. Obviously, I'm somewhat biased about research, but we look forward to hearing from many of you and the impact your work will have in the future, and by virtue of the launch you got here at this incredible program at VTCSOM. So what I'm going to do is talk a little bit about some outstanding mentors. You've already heard and seen pictures of a number of them that you know. And what I'm going to focus on now is a particularly outstanding mentor. So I think, as everybody knows, we have a solicit nominations every year for the outstanding mentor from you, from all the students in the class and so forth. And I want to iterate what the parameters are that we make this decision based on. So firstly, somebody that creates an environment in which original, hypothesis-driven research is effectively implemented and guided. Secondly, they provide opportunities for your professional growth. Thirdly, they challenge you to make original research contributions and to carry your research to completion with rigor. Next, fostering intellectual growth and technical proficiency. And finally, establishing clear expectations and maintaining high standards for quality, research, ethics, and work ethic. And I think you will agree, all of you, frankly, that your mentors have really all done this to a degree. But like anything in life, sometimes somebody really, really stands out. And we want to honor that person today. Now, before I get to mentioning who that person is, let me say a little bit about them and read back to you some of the things you shared with us in commenting about why this particular mentor should be selected. And I guess I'm going to give away 50% of it by, I'm not going to say their, I'm going to say his or her. So anyway, his mentoring style, akin to that of a big brother, provides guidance, support, and encouragement, even with his commonly perceived off-putting personality. That's interesting. Yeah. He is intentional about fostering success and growth of those under his mentorship. It's evident that research is not merely a hobby or career, but an integral part of his life. He has a curiosity for research that focuses on the fundamentals and academic rigor that makes this domain so special. He is always purposeful with his feedback and finds ways to reveal how we can grow as young researchers. He has a remarkable blend of personal and professional characteristics. Now, the last one I'm going to read is my favorite. Following most presentations, you always hear the same comment: great job, excellent visuals, well done. While these comments all intend to encourage the presenter, they really don't do much to add to the conversation, improve the presentations, or provide growth opportunities for the presenter. It is in this domain that Dr. X excels. You will never hear him say that any of those comments in isolation. In fact, the vast majority of the comments are criticisms of the presenter or the presentation. The intent behind those comments, though, are not derogatory or demeaning. The intent is to allow for improvement in all facets of the presentation. Personally, this is how I see a true research mentor. Not an individual that blanketly encourages and accepts mediocrity, but an individual who provides positive criticism and demands excellence. So if that sounds like anybody you know, I would like very much to welcome to the stage to give the award to Dr. Peter Appel. Peter. Words from Dr.
So, thank you. I really appreciate the honor and I appreciate the opportunity to say a couple of words to the young minds. So I think from a fundamental standpoint, right, you want to ask yourself, like, why do we do research? It's not because you're required. It's not because you want to get into a good residency. It's because there's a natural flaw in human psychology. You know, there's this bias for those of you that study knowledge called post hoc ergo propter hoc. It means after the fact, therefore because of the fact. We have a natural psychological inclination to connect two events that occurred one after the other, but that we know are unrelated. I wore my lucky socks and the Seattle Mariners won. Therefore, they won because I wore my lucky socks. If we all believed like that, we would rarely come to true conclusions. Additionally, we have an incomplete understanding of the world when we just look at it. If we didn't investigate, we would all still believe that the world was flat. Put simply, the goal of research is to find truth, not my truth, not Oprah Winfrey's truth, where we all have it internally, not a relative type truth, but real truth, knowledge, which is a justified true belief. And just because you believe something doesn't make it knowledge. There has to be a basis for it. There has to be evidence. And its core, that's what research is, and that's why we do it. But in a large medical center like this, where we have other goals, take care of patients, teach young minds, we have other goals of research. One of which that Dr. Freelander mentioned is we want to have an impact on patient care. As physician scientists, it's our goal to do studies that have meaningful impact. Here are a couple of studies from this group, from medical students, published in the orthopedic literature from us that have had direct impact. I've had multiple orthopedic surgeons come up to me at meetings or in our department and say, I saw the study that, such and such that you did, and this is how I've changed my practice. So that's one of the other goals that we as physicians have that's different than pure scientists or basic lab scientists is we want to make an impact on patient care. Our department has a three-part research mission. We want to impact patient care, but we also use research as education. For those of you here that are learners, whether you're in medical school, PA school, podiatry school, research is part of the educational curriculum. It's something that we teach, even though you may go into practice. And lastly, for many of you who were seeking to get into medical school, for those of you that are seeking to get into certain residencies, we use research as an opportunity for mentorship. So that's how those of us that are in practice use research in those three areas. So our research education in our department, I'm very proud to say in the last 5 years, we've had 25 students in our department that had a primary mentor, and 5 of whom have received letters of distinction. But probably the thing I'm the most proud of is that they all didn't go into orthopedic surgery. I mean, we're kind of a subspecialty, right? Of surgery, we're a subspecialty of surgery. But our students, including those that have won awards, have gone into family medicine, general surgery, internal medicine, and OBGYN. And that is a very proud moment for me. Proud, very excited moment, I guess, is a sort of a proud papa moment, because that means that whatever they got from us will be generalizable. It's not specific to the ACL or the meniscus. It's generalizable to their medical education in whatever field that they're choosing to go into. Other things that you all can think about now as you go forward is you're entering the group of physicians, physician scientists, and physician mentors. And you'll eventually have people that want to look to you for mentoring. So we have in our department a pre-medical mentoring program. I won't go into the details, but you all know medical school is competitive. And there are people that are going to come to you in your careers that want to get into medical school, that want to work with you, that want to do research. And you can look at that as an opportunity for mentoring. In our department, we created this single experience where we brought people in. We had them work on our clinics as scribes. We had them work on our lab as scholars to give them research exposure. And remember, as you enter your practices, is you have something that people want. They want to have clinical exposure. They want to have research teaching. And our program has met with success, and I think that you will meet with success too as you go into your practices. For us, our future directions in our department is to continue to perform this sort of 3-part research mission: clinical outcomes with the faculty that impact patient care, using research as education with all of the learners that we touch, whether they be medical students, the residents through our GME programs in podiatry, plastic surgery, orthopedics, or collaborations with Virginia Tech and the engineering students. Research is part of their required education, and we as research educators provide that to them. And then lastly, remember that research can be mentorship for those that are looking to advance their careers and develop on to the next level. It's an instrument for you to have some impact and influence on them. And you might ask yourself, like, why spend so much effort, right? What impact does this mentorship have? And just like Galileo had an impact on us now, centuries later, we have the opportunity to have impact on generation upon generation. You know, think of it as not a pyramid scheme, not as a virus, but in a more positive way, where your influence affects them in a fundamental way, in a pedagogical way, and then that influences their learners, and then so on and so forth. And then together, what we teach with the hypothesis-driven and scientific inquiry becomes more common and helps us to overcome our natural flaws in our psychology, improves us as individuals, and improves us as a field. And by promoting this scientific thinking in medicine, we make medicine better. We make our teaching better. We make our mentorship better. There's an old expression that says, if you give a person a fish, they'll eat for a day. If you teach them how to fish, they'll eat for a lifetime. And so that's our goals with our research program, is the advances we make in patient care will quickly become outdated as the next study comes along and builds upon the knowledge that you laid the foundation for. But the fundamental principles that you teach the students and the mentorees and that you come in contact will perpetuate themselves ad infinitum. Thank you very much. Do I take questions? Probably not that kind of presentation. I don't think so. Thanks.
All right. Well, now we're going to have the opportunity to hear from some of our class of 2024 researchers. Yay! So we're going to hear from our students who were selected to receive letters of distinction in research scholarship. And so everybody does an oral presentation sometime between year 3 and 4. And we ask all of the evaluators and our faculty who are there and mentors, how would you rate this presentation? And our faculty are looking for things like overall quality of the project, significance, relevance, impact. So these are the sorts of values, not did you finish the study, but the study design itself, the research project itself. And so we're going to hear from several speakers. This first session, we're going to hear from 5. And I just want to remind everybody that we will be taking questions at the end for these particular talks. So there will be 5 minutes for questions. Dr. Nikki Worthington, who's our Director of Clinical Research Education, will be handling the questioning portion of this. And so we also know that this is streaming on YouTube. So if you've got a question, put it into the comments and we'll be trying to monitor that so we can read those out loud as well. But we're going to go ahead and get started with our first student talk. So Abi Butada worked with Dr. Stephen LeConte. Yeah, okay, that's So Abi did his research with Dr. Stephen LeConte and FBRI and Dr. Mark Witcher in the Department of Neurosurgery. And I distinctly remember when Abi was a first year proposing this study. He's using a piece of equipment that is really new, and he's going to tell you about it. And I knew the state of that piece of equipment at the time, and he was convinced he was going to bring clinical patients in to do a study. And I said, sure, that's good. That it's good to be ambitious, because usually you start with healthy controls and you validate the instrument works okay. But what you're going to hear about today is an actual study that includes some clinical patient population. So congrats, Abi.
Thanks, Dr. LeConte. Good afternoon, everyone. Today, I'm going to be talking about an exciting new technology called optically pumped magnetoencephalography, or OPM. This is a non-invasive technique that allows us to study the brain and localize where brain activity is coming from. So jumping right into it, magnetoencephalography, or MEG, is a completely non-invasive technique that measures the magnetic signals that are naturally occurring in the brain, and it uses that to localize where the brain activity is originating from. So you might be wondering, like, why even bother going after magnetic signal when you have simple tools like EEG to quickly measure the electrical signal. If any of you have worked with EEG, it's super noisy, really hard to actually get good relevant data. So one of the big reasons for that is because the electrical current is impeded by the overlying structures of the brain, like the skull and the scalp. This isn't the case with MEG. So you're actually getting a better signal and therefore a better source. So MEG has been around for a few years now. Over here on the top right, you can see what the MEG looks like, the conventional MEG systems. The reason why it really didn't kick off is because it's really expensive. And one of the big reasons for that is the sensors they use require special cooling mechanisms for them to function. So that's why here you see a big tank where the sensors are stored. Additionally, since it requires this doer, patients need to be placed inside this rigid helmet head cast, which makes it fairly uncomfortable for the participant and also not amenable to all types of participants. In recent years, however, a newer system was developed. This is the OPM system that you see on the bottom right. As you can see, it's very different from the conventional model. The sensors can be placed directly on a participant's scalp, making it really comfortable for them. They can freely move. And more importantly, it doesn't require any of that special cooling mechanisms that the conventional model needed. So you're reducing the cost significantly. So the main problem is that conventional MEG is costly, it's rigid, it's not adaptable. So really there's a better need for a more practical and cost-effective solution. OPM kind of solves this issue in a cost-effective manner, but it's relatively new. So there's only about 5 of these around the world. We've been fortunate enough to have one here at Virginia Tech to really pioneer some of this research. But given its novelty, a lot of the way we analyze the data, the way we kind of look at the data is still being developed, which brings me to the aims of this project. First, we wanted to show that we can actually collect healthy control data and localize normal brain function and set the stage for how we can actually apply this to clinical populations. So kind of focusing on that first aim, we partnered up with one of the first sites to develop OPM at the University of Nottingham, UK, and really relied on some of their expertise to develop a cross-site study where we asked participants to do a task which targeted 2 distinct regions of the brain. This is the visuomotor task. So participants were asked to use their right index finger and press a button repeatedly while a visual stimulus was being displayed. Each participant underwent 50 trials, and you can see the trial structure here. They had first 2 seconds where they saw the visual stimulus, they were pressing the button, followed by a 5-second rest period. One of the big differences across both sites, since VTC's relatively newer site, was the number of sensors. To combat that, what we did was we clustered most of the sensors where we expected the activation patterns to occur. So overlying the motor and occipital regions, or the visual cortex. So before jumping into the analysis, it's important to kind of understand how brain signal is analyzed. And one of the ways in which we understand brain signal is different brain wave frequencies. So depending on whether or not you're doing a specific action or whether you're at rest, you might see some frequencies over others. And specifically for our visuomotor tasks, the 2 frequencies that we're interested in and where we expect to see activation is in the beta waves and the gamma waves. And we'll kind of understand that a little bit more with the analysis. So for the first step, we want to look at the sensor level and just see across each sensor, are we getting any changes in activation? So I've highlighted 2 of the sensors, one which is sensor Q here, and one which is sensor A. So sensor Q, kind of focusing on that, that's overlying the motor cortex. Where we expect to see the changes are in the beta wave, and that's between 20 to 30 hertz. So that's kind of where it is in that spectrogram. So here, what you're seeing is on the x-axis is time, which is the trial time, and on the y-axis are the different frequencies. And a spectrogram is just a heat map that allows us to see changes in time for each subsequent frequency. So in the beta waves, you're seeing a decrease when the participant is pressing the button. And that's followed by a rebound increase. And this is known as the movement-related beta desynchrony. So that's what you would expect. And I've plotted below an average across all the trials just to kind of show the brain signal power. Again, this is being driven by the beta wave, but you can clearly see that during that active window, when they're pressing the button, there's a decrease in power. And as soon as they stop, you see a rebound increase. Now, switching gears, simultaneously, we are also activating the participant's visual cortex. And at the visual cortex, where sensor A is overlying, you see something different. You see activation in the gamma wave specifically. So when there's being presented this visual stimulus, you see an increase in that gamma activity. That's what you're seeing in that 30 to 100 hertz region. And then as soon as the visual stimulus is removed, it normalizes. And that can be highlighted with that kind of change in signal power as well. So at this point, we really only know on a sensor level, we're kind of seeing some of the changes we expect to see. But what does that mean? We need to actually get down to where the source is. So to do that, we do a source reconstruction analysis. And we use a mathematical model called a beamformer. This allows us to identify specific regions in the brain that show a specific signal pattern. And it does this by dividing the brain into a set number of voxels. And at each voxel, it uses information from all the sensors to calculate what does the brain signal actually look like there. So here you can see kind of two examples, one with the green dot. It's showing that you see signal and it's taking information from all the sensors and telling you what that signal looks like. So understanding that, we're kind of calculating across 3D space what the signal is looking like. And then we can look for contrast between our active time window versus our control time window and highlight regions of interest. So for this, you only really need 1 second from the active window and 1 second from the rest. But it'll make more sense here looking at an example, what we're actually looking at. So focusing on the left over here with the movement-related activity, again, we're looking for that beta desynchrony. So when there's the active window, you're going to have that decrease in activity followed by an increase. So you're following that contrast. And the beamformer can then tell you where exactly that contrast is occurring. And lo and behold, it occurs right over the motor cortex, as we expect. I've picked out one of the points which shows that peak desynchrony just to kind of plot it on panels B and C, just to prove that we are actually seeing what we expect. And simultaneously, we're also activating the visual cortex. So again, this is a little bit different signal pattern. You're actually getting an increase in that gamma activity followed by a decrease. So where that occurs is overlying the visual cortex, pulling out where the peak contrast is and plotting that, we see that signal pattern that we expect to see. Doing this across our cohort, we averaged and plotted this over a normalized head model, just to compare each group and make sure that we are seeing the activation patterns over the regions of the brain of interest. So across the movement and also the visual related activity, we see it where it's expected. There is some variance across both sites. That could be due to a multitude of reasons, different scanner systems, different inter-subject differences. But overall, we were really happy because we were able to kind of localize simultaneously two very distinct brain patterns. Now, switching gears, we want to see how this is applied to clinical populations. And one of the big clinical populations we were interested in are those with drug-resistant epilepsy. So these are patients who are on anti-epileptic medications, but they're still having breakthrough seizures. And oftentimes they will require surgery. So a lot of the planning before the surgery is really identifying where is their diseased tissue coming from. So epilepsy has been studied for many years, and there's been various zones in the brain that have been defined to actually play a key role in the epileptic presentation. So understanding where those zones are really guides our treatment plan. Removing certain zones, for example, in surgery will benefit patients later on. There's various diagnostic tools that allow you to do this, but there's no perfect tool out there. And we're still unclear where OPM will lie in all of this, but that was kind of our motivation for the study. So we recruited 3 participants with drug-resistant epilepsy. They were asked to continue taking their seizure medicines because we're not trying to induce a seizure in this study. We're only looking at the abnormal events that occur in between seizures. So participants were instructed during the scan to just rest with their eyes closed. And we scanned in 10 minutes of intervals of 10 minutes, and the whole scan lasted between 30 to 40 minutes. So prior to their scan and the OPM, we had an idea of where generally their activity was occurring from, and that helped us guide where our sensor placement was. Again, we still have a limited number of sensors, so it was important for us to know to kind of guide and maximize the area where we're interested in. So across each of these subjects, we get these discharges that you see, and these are these really sharp spike-like events. Just given the nature of epilepsy, you might scan a patient for an hour, hour and a half, you might not collect any of these events. But as you can see here, with the variance of number of events that were collected, we did collect a varying amount of events for each of our subjects. Once we collected the events, they were trimmed, they were marked and taken 2 seconds prior to the marker and then 4 seconds post marker. Those trials were averaged, and then following the analysis, it followed very similar to how we analyzed our healthy controls, where we looked at the sensor level and then finally did the beamformer to look at the source of where this is coming from. For the active window versus the control, we were looking at those first 300 milliseconds right at the onset of the event. And then following that, that was compared to the baseline activity just 1 second prior. So looking at subject 1 here, this was a right-handed male who presented with video EEG and bilateral frontotemporal discharges that were mainly on the left hemisphere. They had 2 focal seizures that were left onset with video EEG, and their intracranial EEG showed similar pattern, bilateral frontotemporal activity, left greater than right. And then they collected 5 seizures, which originated from the left amygdala. OPM actually showed quite concordant results, with frontotemporal activity being the peak activity. And I've plotted kind of that activation pattern for the voxel, which showed the peak activity, just to prove that we are actually seeing this epileptic event. Subject 2 was this right-handed female who had on video EEG right frontotemporal activity and 4 complex seizures that were in the right hemisphere. Didn't really localize to a particular region. On intracranial EEG, it was more focused to the right anterior hippocampus, and that they collected 6 seizures, which were generalized to the right hippocampus. OPM was fairly concordant. It was a little bit lateral to what we'd expected, but we did get right temporal activity as well. So it correlates really well to what we saw in the prior clinical exams. Finally, this was the trickiest subject we had. The left-handed female, they collected left frontotemporal slowing. They didn't actually collect many discharges for this participant, and they didn't collect any seizure events on video EEG. On intracranial EEG, however, they did get bilateral mesial temporal activity and 4 seizures that were in the left mesial temporal lobe. OPM results were fairly discordant. You can see we are getting this kind of central activity, not really what you would expect to see. We anticipated what happened here was we were collecting left and right discharges, and we got kind of a centralized location for that. But still, compared to video EEG, we actually got a lot more knowledge. So I think it still proves to be really helpful. There's often times with specifically these types of patients, they'll target the left anterior region of the brain for surgery, and then after surgery, they find that the seizures have moved to the right. So it's not perfect. OPM is still not perfect. There's still some room for improvement. So kind of the key takeaways, we set up a key collaboration with the University of Nottingham and did a cross-site validation to make sure that we're actually collecting valid data and reliable data. We were able to show with our visuomotor tasks that we are able to localize simultaneous activity in very distinct regions of the brain and with very distinct signal patterns. This really set the stage for us when we wanted to study patients with epilepsy. Oftentimes they'll have a multifocal epilepsy event. So with all our cohort, we were able to detect this abnormal epileptic events and also localize these events, which was really great. So kind of looking ahead, we think that OPM can be really useful in the clinical setting. It's a cheaper version of the conventional MEG. And soon, once we do get this in the clinical setting, we can actually test and look for seizure events or ictal scans. I think OPM will be very useful when it comes to surgical planning, especially because we need to know exactly where the abnormal brain is compared to healthy brain. And I don't think this will be the only clinical indication for this. I think in the future, they might find more uses for this technology. So I'd like to first thank my mentors, Dr. LeConte and Dr. Witcher, and also all the contributors who really helped with this project, and Virginia Tech for really kind of helping me, giving me the opportunity to do this project. And thank you all for your time.
Thank you, Avi. That was a fantastic way to start
Thank
us
you.
off. I want to invite people in the back. We have lots of room down here in the front. So if anybody wants to come down here while we're doing questions for this one, we encourage that. All right, so let's open up the questions for Avi.
Hey, that'd be great. At the risk of offending Dr. Appel, it really was excellent. And and diving in early on a project like the technology is a real challenge to encourage. My question to you is, I'm trying to see if you've thought about how to regress these data. And what I mean is, if you were to follow your patients, particularly let's take patient 3, longer, longitudinally, might the activity pattern you see with OPM be potentially predictive as a biomarker, if you will, of future ictal events that are going to happen? So I guess the question is two parts. Did you do anything like that? And if not, what do you think about that?
Yeah, that's a really good question. So clinically, MEG is being used right now. We have not gotten to that point where we're kind of testing people longitudinally, but that is one of the questions we have in mind, is to track these patients and see, like, those patients who got surgery, okay, if we remove the part of the brain that OPM showed and all these other tests showed, or if there was discordant, then what does that tell us and what are the outcomes? That is eventually the goal, especially because conventional MEG has been shown, especially these interictal events, to be predictive of better outcomes. So they've removed regions of the brain that conventional MEG has shown to be epileptic onset, and that's proven that it has better outcomes for these patients, basically seizure freedom.
You have any other questions? We also have 2 microphones that you guys are welcome to walk up to.
So this test really needs a patient who's really awake, alert oriented, right? Because it's very hard for, like, I mean, we use the EEGs in hospital for somebody with altered mental status and stuff like that, because it's I see it very hard for somebody to kind of click all these when he's not, for somebody who's like 80 years old, who's altered mental status in the hospital. So you think this is going to be not really exactly taking the EEG role or right? I mean, can you explain that a little?
Yeah, sure. So I think I should have clarified more. The first part of the talk was really focused on healthy controls, just to see how this technology functions and kind of set up the way we analyze the data. The second part, we're not actually having participants do any tasks. We're just having them rest with their eyes closed. They could be resting or in an altered state as well with that part, because we really aren't trying to induce any seizures at this time. We just want to get their baseline resting state activity. And you're exactly right in saying that this isn't probably going to completely take over EEG. It'll probably be a select few patients who video EEG doesn't really give us a clear picture, and other scans don't give us a clear picture, where OPM might come in and give us some more data.
Any other questions?
Hey.
So for your proof of concept at the beginning, you were able to localize two different voxels using the sensors that you already had. But for patient 3, you said that one of the confounders for why you kind of ended up with that midline signal was that it was kind of a amalgamation. Everything came together and just you get left to right and you ended up in the center. So is there any kind of approach that you guys might take differently, either with the analysis or with adding additional sensors that you think would allow you to then identify multiple voxels for people who do have bilateral activity?
Yeah, it's a really good question. So certainly adding more sensors will give us more information to kind of tell us where exactly this source is coming from. Additionally, we're working on a new pipeline where we can look at single events and map those. And that way we can categorize each event, and then we can localize all the events that look very similar, and that'll give us a better picture of those events versus others.
Hey, Abby, great talk.
Thanks.
So I noticed that one of the common paradigms to look at some of this interictal activity, these high frequency oscillations between 80 and 500 hertz. But I noticed that when you bandpassed your data, it was 1 to 70. Do you think that based on the lack of limitations of the skull with OPM and MEG, that using some of these higher frequency oscillations might improve your beamforming and your localization capabilities?
Yeah, so high frequency oscillations are kind of a hot topic right now in the epilepsy field, especially because they've shown with conventional MEG that that's highly predictive of the seizure focus. So right now, we really only targeted the basic interictal activities to compare directly to our clinical standards. But eventually, I do foresee that we will target those high frequency oscillations as well.
Any other questions? I think we have time for one more. All right, thank you very much, Abby.
Thank you.
So our next presenter is going to be Megan Knapp. She worked with Dr. Jake Gillen from the Department of Surgery. And Megan is known as a productive and self-sufficient researcher. And I think you're going to hear about that when she describes her research. But I just want all of you out there to know that one piece of evidence to indicate that is the fact that she got 2 IRB protocols approved during her time here and gathered data on both of those. So it's impressive.
All right. Hey, everybody. My name is Megan. I'm a 4th year here, and this is my talk on optimizing trauma triage at Carling Clinic. So before we start, there's a couple of definitions that we all need to be on the same page for. The first of which is trauma triage. And so this is how we identify how severely injured we think an incoming trauma patient is, ideally prior to their arrival at the hospital, so that we can activate the appropriate trauma team activation. Trauma team activation, or TTA, is mobilizing specific people and resources for that trauma patient, and these are based on predetermined criteria. These are an example of some of these criteria. I don't want you to read through all of these. It's a lot of words to be on a slide. But what I do want you guys to understand is that these 6 minimum criteria are required to be in place at every level 1 trauma center for their highest level of a trauma team activation. The other important thing is that hospitals very frequently add to these criteria as they see fit to address the unique needs of their patient populations. And this is where a lot of prior research on trauma triage has been focused. The problem with that is that it's hard to generalize that because everybody's looking at unique patient populations. So when you add to these 6 minimum criteria, you may end up with something that looks like this. So this is what Carling's adult trauma team activation criteria looked like. We have 3 different tiers for trauma team alerts. The full alert is the highest level with the most amount of resources activated. And you can see those 6 minimum criteria from the last slide highlighted in bold here, all the way down to the trauma console, which is the lowest level. Ultimately, the goal of any trauma triage system is to identify who's most critically injured so that we can assign resources appropriately and optimize their outcomes. Unfortunately, for a variety of reasons, patients don't always get the trauma team activation level that they need based on how injured they are. And when that happens, we call that mistriaging that patient. I'll talk about how we define whether or not a patient has been mistriaged or appropriately triaged later on in the methods section. But here I'll tell you guys that there are 2 types of mistriage. There's under triage and over triage. Under triage is worse than over triage because it's associated with increased patient morbidity and mortality. And so we try and keep that pretty low at less than 5%. We get a bit more leeway with over triage. We try and keep that below 35%, but it does still have its bad side effects. It's associated with inefficient time and resource utilization as well as provider dissatisfaction. hospitals across the world struggle to reach these optimal rates. Rates of under triage in the literature have been as high as 30%. And the thing that kind of kicked off this project, and when I started on it, was that we calculated rates of under triage at Carilion as being 10% and over triage is 43%. So our overarching research question was, how should trauma centers optimize trauma triage? And the general hypothesis was that a two-tiered approach of first improving compliance to the trauma team activation guidelines, followed by modifying them as necessary, will increase rates of appropriate triage. This was a two-part study. The first part was focused on improving compliance to existing guidelines. So we looked at our original guidelines and we looked at triage patterns before and after we implemented an intervention designed to improve compliance. The second part was focused purely on the triage patterns before and after the criteria were modified. The methods for both sections of the study were nearly identical. The way that we analyzed the data was the same. Our data sources were the same. We used the Carilion Trauma Registry and supplemented from the medical record as needed. We classified patients as mistriaged or appropriately triaged using STAT, which I'll bring up on the next slide. Everything was conducted retrospectively. We used Welch's t-test and Fisher's exact test for our continuous and categorical variables respectively. And everything was analyzed in R with an alpha level of 0.05. So at Carilion and at many trauma centers, this is how we classify whether or not a patient was appropriately triaged, AT, over triaged, OT, or under triaged, UT. So it can get kind of complicated to go through this, and I'm not going to spend a ton of time on this slide. But what I want you guys to understand is that every patient that comes to the hospital basically goes through two different filters to figure out if they were triaged appropriately. The first filter is the Krabari method, and that looks at how severely injured the patient was or using their injury severity score. The second filter is the need for trauma intervention, and that looks at what interventions the patient needed after they got to the hospital that are associated with high mortality and morbidity. And so using those two filters, that brings us to the final designation of if they were appropriately triaged or mistriaged. So moving on to phase one. So this is where we focused on improving compliance with existing criteria. So on May 12th, 2021, there were a series of workflow interventions that were implemented in the ER designed to improve compliance. And that's what's depicted on the figure on the right here. So on the left-hand side, figure A is the original workflow. So originally what would happen is EMS is bringing in a trauma patient. They call the hospital, they're connected with a dispatcher, and the dispatcher pages an emergency department attending. That attending takes the call. They decide whether or not the patient has met trauma team activation criteria. And if so, they choose which level to activate. So a full alert, partial alert, or consult. The dispatcher then transcribes the reason for alert into a free text box. The modified workflow is shown on the right here. There were two major changes. The first is that when EMS calls the hospital dispatcher, the dispatcher is the one that takes that report and determines whether or not the patient meets criteria for a trauma team activation. And if so, the way they make that activation is by selecting which criteria have been met from a drop-down menu rather than typing it into a free text box. So the idea here is that we're using technology to really drive how these alerts are being activated rather than relying on memory for clinical decision-making. Because the intervention went into effect on May 12th, 2021, we compared patients who presented in May through December of 2020 versus 2021. We excluded patients who had no trauma team activation, direct admits, and who had no date of arrival recorded, and we ended up with these as our pre and post intervention cohorts. The first thing we wanted to do was make sure that the groups were pretty similar in terms of their patient characteristics between the years. So we looked at demographics, how the patients were injured, and then physiologic parameters, which were essentially their vital signs. So heart rate, systolic blood pressure, injury severity score, and Glasgow Coma score. This is a huge table, and I'm not going to spend time here. The too long don't read version is that characteristics were similar between groups. The only ones that were different are highlighted, or statistically different, were highlighted in yellow here, but there wasn't a clinically significant difference here. The next thing we wanted to do was see if compliance was actually improving, because that was the whole point of this intervention, was to improve how we were following our criteria. So to do so, we looked at patients who met isolated, objective, full alert criteria as reported by EMS. So these were basically vital sign criteria. So we have the heart rate criteria here, systolic blood pressure, respiratory rate, and GCS criteria. A patient with any of these criteria before they get to the hospital should be receiving a full alert. So for example, say EMS has a patient coming in with a heart rate of 50. If they received a full alert, we marked them as compliant. And if they received either of the 2 lower level alerts, we marked them as non-compliant. And these were the results from that analysis. So on the x-axis here, you can see overall compliance followed by the individual isolated vital sign criteria that we looked at. And on the y-axis is the rate of compliance. So what percentage of those patients with those vital signs got the full alert like they were supposed to? We saw a significant increase in overall compliance. And in general, we saw trends towards increased compliance in every criteria with the exception of tachypnea. So we concluded that the process intervention was associated with improved compliance. The last thing that we looked at here was rates of appropriate triage and mistriage, because the ultimate goal of this project is to improve appropriate triage. What we saw, and we were really happy about, is that under triage, which is the worst form of mistriage, basically dropped in half. We dropped from about 6% to 3%. And importantly, we crossed that threshold to get to below 5%. Unfortunately, we also saw that the intervention was associated with a pretty big increase in over triage, and this increase was so large that it decreased our rates of appropriate triage. This led us to kind of zero in on over triage as a potential target for the second phase of the study, where we were going to be modifying trauma team activation criteria. And again, we looked at these isolated vital sign criteria, and this graph is showing the percent of patients who presented with these criteria who were over triaged. The criteria that are highlighted in red here are the ones that stood out to us as potential targets for modification for a couple of reasons. First being that hypotension can't be touched. It's a minimum criteria, so we can't do anything about that. But second, because the increase in over triage was pretty drastic, and there was a fairly large proportion of these patients that were being over triaged. When we further looked into what percentage of over triage patients were composed of patients with these criteria, we saw that they were making up a large proportion of over triage patients. So not only are they being over triaged frequently, they're making up a lot of our over triage patients. I did an additional analysis on patients with isolated tachycardia, and I zeroed in on age. The reason being that there's a really big push for trauma centers to incorporate geriatric specific criteria into their protocols, because it's very well known at this point that geriatric patients have higher morbidity and mortality than non-geriatric trauma patients. What I found is that even though the rates of over triage were similar between geriatric and non-geriatric patients, there were far more non-geriatric patients who were being over triaged compared to geriatric. So we proposed removing tachycardia as a trauma team activation criteria for non-geriatric patients only. We did go back through the data and look at patients who met these criteria who had been triaged appropriately, just to make sure that if we had taken these criteria out, we wouldn't be all of a sudden bringing in a bunch of new under triaged patients. And there were similar analyses done by other members of the team that supported completely removing bradycardia, bradypnea, tachypnea, and chest wall and pelvis instability. So these are the criteria that are highlighted here on the right. So from phase 1, we concluded that the process intervention was associated with increased compliance. This increased compliance was associated with a significant drop in under triage, which got us to the point of being less than 5%. But this was at the expense of increased over triage that ultimately decreased appropriate triage. However, not every criteria increased in over triage to the same extent. And so these were potential targets for the next phase of the study. And the fact that our triage patterns changed so drastically after just improving how well we were following them suggested to us that compliance is a necessary step in accurately evaluating how well these criteria are to start with. So moving on to phase 2. So this is when we looked at triage patterns before and after the criteria were modified. The criteria that are highlighted in yellow here were removed, and these were the criteria that we talked about as being targets during phase 1. And then here on the right, you can see the addition of the geriatric specific tachycardia criteria. You'll also notice that it was downgraded to a partial alert criteria from a full alert criteria. And this was due to it still did have quite a high rate of over triage. So we were hoping to address some of that by downgrading that as well. The way that we defined our cohorts was identical to phase 1. These criteria went into effect on January 1st, 2022. but we chose to analyze patients presenting in May through December of both years again to match the seasonal variations in trauma patients because people get injured differently at different times of the year. And so the exclusion criteria were the same, and we ended up with these as our original and modified criteria cohorts. Again, we looked at patient characteristics. Again, they were generally similar between groups. The ones that had statistically significant differences were not, they had small effect sizes and were not clinically significantly different. These are the triage patterns before and after we modified our criteria. So on the x-axis here is the triage status, and on the y-axis is the rate of triage. What we saw is we were able to get a significant increase in appropriate triage due to the significant decrease in over triage. We saw a small non-significant change in under triage, but again, we remained under that 5% threshold, which is really important goal, and we've been able to stay under that threshold since. We did go back and look at compliance again, because that was the whole point of phase 1, was to improve compliance. And we wanted to make sure we were still doing okay on that front. So on the x-axis here, again, you can see overall compliance and the isolated vital sign criteria. And on the y-axis is the rate of compliance. And the compliance either increased or remained high for all criteria. So we were doing okay on that front. The last thing that we looked at was we looked at all 3 years together. So this is triage patterns for 2020, which is before we did anything, compared to 2021, which is after we improved compliance, compared to 2022, which is after we modified the criteria and the compliance intervention was still in place. And when we looked at this, just, you know, looking at it straight on, it looks pretty similar to when we started. The 2022 patterns look pretty similar to 2020, with the exception of under triage reaching that 5% threshold. Why that's important and what that tells us is that we were likely grossly overestimating how effective our criteria were to start, because our compliance with those criteria were low. It's really important because one of the biggest ways that trauma centers seek to improve trauma triage is by modifying their criteria. And they may choose to modify or not modify their criteria based on triage patterns. But if their triage patterns are not reflective of their actual criteria due to low compliance, it's hard to make an accurate decision on how they should change their criteria. Once we optimized compliance, we were able to modify or remove 5 criteria, which really simplified our criteria quite a bit, with positive changes in AT and OT, kept under triage below 5%. And we also incorporated an example of geriatric specific criteria. Like I said, there's a huge push right now in the trauma field to incorporate geriatric specific protocols into an institution's trauma team activation criteria. And this is an example of how you can do that by breaking down different criteria by age. The study supported that optimizing compliance should be an institution's first step in analyzing the efficacy of their criteria before making any modifications. On a totally different note, the fact that we were able to make triage patterns near optimal using dispatchers designating the trauma team activation levels supports that emergency department physicians may not need to carry the burden of calling all of these different trauma team activations. And in an era where burnout is through the roof and increasing, especially after COVID and the ER, if we can alleviate some of this clinical burden, that could have a pretty big impact. So overall, this is a generalizable 2-step process for improving trauma triage systems. We want you to start with ensuring adequate compliance to criteria, followed by evaluating and modifying the criteria if necessary. This is the team that I worked with. Dr. Gillen was a really great PI and had a lot of support from him. Pam Baremski was a data queen, and Kara Spivey helped me out a lot with the IRBs, and I definitely would not have gone through those without her. So thank you guys.
Thank you for that wonderful talk. If we have any questions, I'm going to ask you come down to the 2 microphones here at the front.
Hey.
Great talk.
Thanks.
I was kind of wondering from like a human's perspective, what are like the things that are leading to the non-compliance, right? Is it like not understanding kind of what the criteria are? Is it not having the information when those decisions are being made necessarily? Kind of give a little insight into that.
Yeah, there's a lot of different things that can contribute to non-compliance. The reasons that you stated are definitely up there. Not knowing the criteria can certainly lead to someone triggering an alert for an incorrect reason. One of the other things that can theoretically lead to non-compliance is one of the minimum criteria is that physician discretion must always be allowed. And so theoretically, a physician could hear a report about an incoming trauma patient and make a decision that doesn't technically follow the criteria based on their clinical discretion. And that could have a negative effect on compliance, but at the end of the day, the physician needs to make a final say based on what they believe that the patient is coming in with.
Sure.
Yeah.
Thank you.
Mhm.
Any last questions? All right, thank you so much, Megan.
Thank you.
Now we're going to shift to a different format. So these are going to be rapid fire talks. So 5 minutes, we're going to have 3 of them in a row. And then at the end of all of those talks, we'll have all the students come back up and field questions for any of them. So keep your questions in mind and then jump up to the mics when we get through the next 3. So our next presentation is going to be from Celine Marlon Andrews. So this is a really interesting study that was inspired by a clinical observation and then went back to the bench to investigate. So we love this story. She was mentored by Dr. Greider and Dr. Kristen Eden jointly, and she has some really exciting results to share.
I'm just going to sip a little water first. This is going to be a super quick talk, and it's hard to follow those 2 amazing projects that were just talked about. So big round of applause to some of my colleagues who are presenting their research today. Let me just make sure this works. Perfect. All right, so hi everyone, my name is Celine Marlon Andrews. I'm a 4th-year medical student here at Virginia Tech, and I'm super excited to present this project to you, which is harnessing the innate immune response for potential malignant melanoma therapy. So just to start us off, to let you know, melanoma is incredibly deadly. It's the deadliest form of skin cancer and actually is the result of 75% of skin cancer-related deaths. Despite this shocking number, there remains very few effective strategies for therapies. The primary therapy is resection, although that doesn't always go very well. Chemotherapy is second in line, but again, the survival outcomes are not very great. There was a recent shift into looking at targeted therapies for the upregulations of specific genes in melanoma, but patients often will develop a resistance to these therapies, leaving them pretty ineffective. So in the cancer field in general, there's been a recent shift to looking at whether or not we can focus our innate immune response into a therapy towards cancer. And so that's kind of what sparked our interest here. So raise your hand if anybody in the audience has ever gotten a splinter before. Great, me included. They're kind of annoying, but what's happening there is actually really cool. So your immune system will send macrophages to the splinter, and the macrophages they're trying to eliminate the splinter through processes of inflammation and phagocytosis. So that's what we wanted to see, if we can harness this foreign body reaction that the macrophages are doing to eliminate cancer. And to our knowledge, this has never been done before. So just kind of showing you an image on the right-hand side, this outlines the foreign body reactions. You have a foreign body here on this kind of border. Macrophages are drawn to try to phagocytose that foreign body. And then they form this huge kind of foreign body reaction with a multinucleated giant cell in the center. That giant cell is the hallmark of the foreign body reaction that we want. And so a recent case report given actually by Dr. Apel, who got the Research Mentor Award, showed that a foreign body reaction was observed in a human body following placement of a wound vac, which has a polyurethane foam. So we wanted to use that polyurethane foam as our stimulus for the foreign body reaction. So that leads us to our overarching research question: can we harness the innate immune system to target tumor cells? And more specifically, we hypothesized that utilizing this polyurethane foam will activate macrophages and eliminate neoplastic cell lines through that foreign body reaction. So How we did this, we cultured and treated macrophages and melanoma cells with polyurethane. Here's an image of a wound vac in case anybody's not seen it before. That black foam is polyurethane foam. We literally took this and chopped it up in a tissue culture hood and used that in our experiments. What I'm going to show you today, my data really focuses on immunofluorescence, looking at how cells are responding to this polyurethane foam and also looking at cell death through specific stains. So first off, we took macrophages and we exposed them to the polyurethane and wanted to just see what happens off the bat. What we found was really interesting. So here to orient you, DAPI stains for all cells nuclei. Propyridium iodide is a stain for cell death. So for the rest of the presentation, just remember red equals dead. And then you have a merge on the right. So what you can see here most strongly in the propyridium iodide stain is a multinucleated giant cell, which is great because we're showing that polyurethane, when exposed to macrophages, is stimulating that giant cell reaction, which is the hallmark of a foreign body. And then down here on the bottom row, what you can see highlighted in the DAPI stain, this kind of cross-like structure is actually a fragment of the polyurethane that took up some of the stain. What's cool here is you can see in the propyridium iodide that a lot of the macrophages are binding to the polyurethane and subsequently undergoing cell death. So we were really excited about this and we wanted to quantify it. And that's what you can see here. So the left-hand column is our controlled macrophages, not stimulated with anything. And in the right-hand column, you have macrophages exposed to polyurethane. Visually, you can see that there's more cell death in the polyurethane stimulated sample. And we also found that to be statistically significant. So here, the y-axis is the percentage of cell death, paying attention to our control column on the left and our polyurethane stimulated sample on the right. And the rates of cell death were, in fact, statistically significant. So then we wanted to take these activated macrophages and see what would happen when we expose them to our melanoma cell, because that's really the question we had in mind. So we took these transwells, which is a device that has a well insert here and then kind of a larger well on the bottom. We plated our activated macrophages in the insert and our melanoma cells on the bottom. There are pores in between that allow for the transfer of soluble factors, but not the movement of any cells. So we went ahead and we did control melanoma cells. So B16 are a melanoma cell line. Here you have melanoma cells that are exposed to unstimulated macrophages. And then here you have melanoma cells that are exposed to stimulated macrophages, specifically stimulated with that polyurethane. Visually, you can see that there is more melanoma cell death with the stimulated macrophages. And again, that was statistically significant. So similar y-axis with percentage of cell death. And again, statistically significant increase in the rate of cell death of melanoma cells when exposed to those stimulated macrophages. So what we think is happening here is macrophages are being drawn to our polyurethane because it's a foreign body and they're trying to phagocytose and eliminate it. When it cannot eliminate it, it sends out cytokines, which attract other macrophages from around the area to conglomerate and bind to this foreign body. Some of them merge together into that giant cell that we know as the hallmark. When it's ultimately unable to phagocytose this foreign material, we think they're sending out a cytokine storm, which is ultimately leading to the death of the nearby neoplastic cells. So our takeaways are that we found that polyurethane induces that foreign body response and increases death amongst macrophages. And similarly, we found that the B16 melanoma cells are exhibiting similar rates of cell death when cultured with those stimulated macrophages. And I'd like to highlight, I do have an amazing team. So Dr. LaConte was talking to them. I have another colleague in the audience that has been helping on a different arm of this project. And I see my mentors here, Dr. Eden and Dr. Greider as well. And it's been a really amazing opportunity to work with everybody. So thank you very much.
All right, next we're going to hear from Liam Cleary. I'm getting him pulled up. So I always love it when we have projects that are begun by one student and then carried forward by other students. And so that's the case with the project that Liam's going to present. In addition, you're going to hear about the results that he is going to present, but he in the background is also helping establish things like processes with the Department of Radiology for storing images for analysis. So a lot of a lot of our students go out and help, improve the way we get research done here. So we're going to hear about Liam's work with Dr. John Carmouche from the Department of Orthopedics and Dr. Joe Hughes from the Department of Radiology.
Is that working?
Hi, everyone. So my project is focused on the analysis of quantitative MRI techniques for cervical spinal myelopathy. Basically, we're interested in what new MRI techniques we could use for CSM. And I'd like to thank Brooke Mitchell, Dr. Carmouche, and Dr. Hughes. So starting off, what is cervical spinal myelopathy? It refers to compression of the cervical spinal cord due to degenerative changes of the cervical spine. So when the spine ages over time, it loses disc height, and in addition, you have expansion and growth of the ligaments around it, and it leads to compression of the spinal canal and eventually compression of the spinal cord, which leads to myopathic symptoms. And the big problem with this is it accounts for nearly 20% of cervical spine operations. However, there's only about 30% of cases report unsatisfactory outcomes. So even though it's very common, it is not well treated, and it's also not well controlled, because current imaging techniques that we get, like T1, T2, and T1 weighted for CSM, cervical spinal myelopathy, do not correlate with functional impairment and pain scores. So we have this dichotomy between images that might show severe spinal cord compression. However, the functional impairment or the clinical images aren't correlated. So going into that, we were interested about what new imaging techniques are there. Is there anything we can use that can help be kind of this objective measurement for this disease that we aren't able to predict well? And that's when we became interested in quantitative MRI techniques. This is basically an MRI technique. Instead of giving you an image, it takes the analysis and the magnetization that you're able to create from an MRI technique to analyze certain cells. So for us, we want to analyze neuronal integrity, specifically myelin. So the first part of our study, we were looking at 1 magnetization transfer ratio. And then I wanted to add additional MRI sequence magnetization transfer saturation, which is basically an upgraded MTR, and see if those can be used for accurate diagnostic tools for CSM. So we want to see if these new imaging techniques, MTR and MTSAT, could be used to clinically predict functional impairment in cervical spinal myelopathy. So our study designs, we had patients 18 to 80 who presented to a spine clinic with symptoms concerned for CSM. We enrolled them. In addition, we got clinical radiological findings to confirm CSM. And then we got 2 functional impairment scores, NERC and Modified Japanese Orthopedic Association, MJOA in short. And then we got MTR, MTSAT images obtained during the same time they would get normal images. So the big was very important to us was we did not add any cost to these patients. We just kept them in the MRI machine for additional 15 minutes after they got their initial MRI images. And then we used the same images from those patients to compare to each other. So both MTR and MTSAT were obtained from the same patient, which allowed us to control for it. And then our inclusion exclusion criteria focused basically upon to make sure that the patient had cervical myelopathy and it wasn't another cervical problem. So that way we can exclude anyone who might have caused any changes in the data. So going into functional impairment scores, these are pretty big. Basically, NERC is out of 5, and the lower you are, the better. And it basically looks at primarily lower extremity weakness. So we got this, and we were focused on lower extremity weakness, where MJOA is a combined score. It's actually out of 18. This is just the motor section of it, but it's out of 18, and it looks at upper extremity function, lower extremity function, urinary function, and then sensation. And this is the standard impairment score used for cervical myelopathy. However, we want to look at both of them to see if there's any difference between the two, but we're specifically focused on MJOA to see if the images we obtained correlate to the functional impairment scores. So our initial results, we had 14 patients enrolled, and their MJOA was 15.5 on average, and their NERC value score is 1.583. So this was pretty mild to sum it up. So 15.5 out of 18 is a pretty mild score. As well with the NERC value, 1.583 was also pretty mild. We had some variance, but there's more variance in the MGOA due to it being larger scale compared to the NERC. And then we obtained pain scores also in these patients. We were looking at length of pain symptoms, neck pain, arm pain, lower extremity pain, and then overall pain scores. And that was found to be 3.583 and then 5.167, specifically at neck pain, as that's one of the earliest symptoms. And then for our obtained radiological assessment values, we had mean lowest MTR 14.283. It was found either to be at the level or lower than the compression. And then the MTSAT was found to be 4.325, which is actually shown to correlate better than MTR with myelin density. And then in addition, we just got some basic demographics showing that we have an age of 57. Majority of our patients were female, BMI of 31, and then the duration of symptoms was 3.73 years. So most of these patients had symptoms for a long time before they presented to clinic, and they've tried most conservative management before this time. So going into the results, comparing MTSAT to functional impairment scores, we found a statistically significant correlation between MTSAT and the MJOA scores. And in addition, MTSAT was found to be correlated with length of symptoms, which correlates, which aligns with previous data that's shown that if you have a spinal cord injury, after about 9 months, you start to see loss of myelin integrity. And these graphs here basically show the MTSAT comparing it to the NERC functional impairment score and the MJOA functional impairment scores. And the reason why NERC has not been found to be statistically significant at this time is due to the ceiling effect, where either our patients only had a NERC score of 1 or 2, so it was hard to parse out the data between that. However, MTR was not found to be statistically significant to NERC or MJOA, showing that the new MTSAT MRI images is a better diagnostic tool as compared to MTR, which correlates well with the data. So in conclusion, we found that MTSAT was found to have a stronger correlation to functional impairment scores and length of symptoms than MTR, and that this quantitative MRI techniques we were looking at has potential to help with cervical myelopathy management in the future, but still needs additional investigation to elucidate its true potential. So this is one of the first imaging techniques or really scores that has been shown to follow functional impairment and follow it well, in addition to be correlated and shown to connect with myelin integrity. So it has big effects on the future if continual research is done. So this way, patients, not only if they have cervical compression, if they have lumbar compression or any cervical spinal injuries, you can use these imaging measurements to predict, okay, how severe are they, and then how do we want to treat them in the future? But does warrant further investigation of MTSAT and other quantitative MRI techniques as clinical tools for CSM. And that's it.
So our last talk for the rapid fire session is going to be from Casey Hoyt. She worked with Dr. Coy Allen, who's in our College of Veterinary Medicine. So she made the trek to Blacksburg to actually gather her data. So kudos for that. And we're going to hear about her work with looking for data in inflammatory bowel disease and predicting some new gene relationships.
Thanks, Dr. LeConte. Hi, everyone. I'm Casey Hoyt. I'm a 4th year. I'm excited to share with you my research on eosinophilic esophagitis in a very special subgroup of patients that get the disease. So first, we'll start with a 5,000-foot view. Eosinophilic esophagitis and inflammatory bowel disease are inflammatory conditions of our gut. So we can just start there. So as we zoom in, here are endoscopic images of an esophagus. On the left, you'll see a normal esophagus that if we scoped someone in here, hopefully this is what it looks like. And on the right is somebody with active EOE. So you can see the beginnings of a concentric fibrotic ring, which is more difficult to appreciate, but I think we can see a longitudinal fissure and some different stages of microabscesses. As we dive down to the cellular and genetic levels, EOE is a Th2 mediated disease, which is overall like an allergic response. And then there's a couple of genes that are hallmarks of this disease, including eotaxin 3 and TSLP, which is thymic stromal lymphoprotein, if anyone is wondering. So hopping over here to the other side of my study with inflammatory bowel disease, this has two categories underneath it, Crohn's disease and ulcerative colitis. You can see representative scopes here. We're most interested in our case in Crohn's disease because that can also happen in the esophagus. So compared to EOE, IBD is a Th1 mediated disease, which is more autoimmune in nature, and the genetics are super complex and we won't dive into them today. So what I've just done is spend about a minute of my time telling you how these things are at opposite ends of the theoretical immune spectrum. And now I'm going to tell you that there's a subgroup of patients that get them both at the same time. And so my research question was very simple. How? So to investigate this question, we got biopsy samples from several patients with control healthy esophagus, people with EOE, people with IBD, and people with that overlap syndrome. We then extracted DNA, RNA, and protein from those samples and used transcriptomic analysis, where we reverse transcribed RNA to cDNA, labeled them with a whole bunch of fluorescent labels, and then looked at differential gene expression. So the first step was to look at just the EOE patients compared to controls. So what you're looking at here is differential gene expression on the y-axis and a bunch of different genes on the x-axis. Red shows upregulated genes and green is downregulated genes, which will be the standard throughout the talk. So our first step was to just check our work. And we found that several of the genes differentially expressed in our samples had been previously reported in EOE. So we thought, okay, we can move on to the next step. We can see what's different. And so if you take a look at these axes, especially down here in the downregulation, you'll see lots of genes that start with SPRR, and then throughout a lot that start with MUC. And those SPRR genes and those MUC genes had not been previously reported in EOE. So we use that as sort of a hypothesis generation step to dig further. And so we put all of these differentially expressed SPRR genes into gene ontology software to look at pathways that could be combined to suggest which pathways might be most commonly involved in these gene families. So we found that the SPRR genes were commonly associated with keratinization, cornification, and epithelial skin barriers. And those MUC or MUC genes were commonly expressed in structural development and lubricant activity, as you might have guessed by the MUC name. So this was just in those control versus EOE patients. So now that we had an idea what we were looking for, we compared those EOE patients with the people with the overlap condition. So the question we're asking on this very busy slide I'm about to walk you through is, how are the EOE IBD patients different than patients with EOE, or how are they the same, to try to get a sense of what are the mechanisms that underlie this EOE IBD overlap syndrome. So we didn't have a ton of samples from these patients. As you can imagine, they're hard to get. But on the left and the right, you'll see the upregulated and downregulated differentially expressed genes that you guys have been looking at now. And so the genes that are outlined in blue are genes that were differentially expressed in our samples with the EOE compared to control, suggesting that there's some similarities between those two groups. Highlighted in pink are IBD genes that have been reported in the literature. We did not have enough samples to compare our own with this sample group, so I just highlighted them for you based on literature review. So overall, what you can take away from this slide is that maybe these overlap patients have features of both conditions as opposed to having something different. So overall, this was a really interesting finding for us. These SPRR and MUC gene families we set forth as potential mechanistic triggers for the EOE IBD overlap syndrome. And we'll have to turn to the literature where those gene families have been reported, often in the gut-skin axis or in the lungs, to figure out how we can better validate and dig further into mechanistic studies. Our overarching goal, of course, is to finally identify a trigger point or an activation area that can be used as a therapeutic target. So I would like to thank Dr. Allen, who is my mentor, the now Dr. Holly Morrison, who is my PhD student, co-researcher at the time, as well as our collaborator over at UVA, Dr. McGowan, who got us all those samples and gave us a wonderful MIL talk a couple of weeks ago on this topic. Thanks.
All right, we're gonna have all three speakers come down to the front. And I'm gonna invite all questions to come down here to the microphones, and you can ask questions of any of the speakers. Thank you. Here's your cheat sheet, so you remember who everyone is.
I'm so impressed with you. It's amazing how much you've gotten done. I have a question for Celine. Did you hear that?
Sorry, yes. Yes.
So I feel like there's been so much excitement in the cancer world around immunotherapies and even for melanoma, like pembrolizumab and things that really trigger the adaptive immune system. But of course, many of those patients develop autoimmune conditions. And this is the first time I've heard about really triggering the innate immune system to attack cancer cells. And I just wonder kind of what is that field of research like? What's on the horizon? Is there hope that there'll be less of these adverse effects with using these therapies?
Yeah, so that's a great question. Honestly, it's not super well reported on right now. There's a couple of like articles in like open access journals, but really not a whole ton, which is kind of one of the novelty aspects of this project is that we are looking at the innate response versus the adaptive immune. So hopefully more on that to come, but there's not honestly, unfortunately, a ton that I can kind of share with that. But there's a lot to kind of support this macrophage kind of activation tool. So hopefully we'll see more. I think we saw another lab, if I'm like remembering back, that was also looking at macrophages. So more on that to come. Maybe they will publish soon too. Yeah, sorry.
Any other questions in the audience for our three speakers? Okay, well, we want to thank you very much. Did you have one online? Oh, great, fantastic.
We have one question online from Dana Wang. Quick question for Celine. Are there other commonly used materials in a clinical setting that might trigger a similar immune response to polyurethane?
Yeah, totally. So that was kind of one of the questions. This foam is not as easy to manipulate as we would have thought. It's quite hydrophobic. If you have worked in the wet bench lab, it like sticks to your pipette tips. It's like very hard to manipulate. So one of the big questions was like, what other kind of products could we potentially use, especially when we're thinking of transitioning this into a potential animal model? And so one of the products that we did investigate and have preliminary data on that I didn't show you today is actually a polyurethane suture. And so it's like suture that you actually use kind of in the OR to close skin. And we cut it up and kind of literally just exposed the macrophage to it and had very similar results. So when we're thinking about what we can maybe inject into a tumor in a mouse model as our next step, the suture is definitely kind of at the top of our forefront. There's also, other biomaterials like polystyrene that we used as well, comes in a bead-like form that also had similar effects. So a couple of different options there.
All right, thank you. Our second poster session is starting. And so if we could ask everyone to head over to the poster room to participate in our other researchers.
Use the QR codes to vote for your favorite student posters, and faculty, please evaluate the posters as well.
Actually done?
Yeah, these are some great projects. Yeah, I know, we
We got them all crammed in.
Yes.
So I think it was immense progress, but, yeah, there's always. Yeah. That's good. You really worked hard. I appreciate it. Really nice to feel it. I was so about. That's yeah, okay.
It's essentially that's, well, they're not our board, those for G 101. Yes, those just, can you just cycle through them? Yeah.
Absolutely.
So they can vote.
That's no problem.
Okay. So who's the? I think. Yeah. The run of okay. You wanna? Very cool. Yeah.
Corral the roots to get a picture of the next one, 'cause I feel like
It was fun. All right, welcome back, everyone. Take a minute to submit your votes for the posters, both faculty and students, poster presentations. We need all those votes in now so we can go tally and then we can give out those awards in a little bit. We're going to continue hearing from our students who were recognized with letters of distinction for their research studies. And first up is going to be Danny Purcell, who worked with Dr. Sammy Lamouille in FBRI. I was recently talking with Dr. Lamouille, and he shared that Danny presented at the American Association of Cancer Research recently. And while he was at his poster, a researcher came up and talked with him. And so he talked through his poster and his remarkable results. And that researcher subsequently reached out to Dr. Lamouille, and they now have an active research collaboration. So yeah, yes, kudos to Danny. I think that this just represents that you all are great ambassadors for our research and the work that goes on at VTCSOM. So we're excited to hear about Danny's research.
Thank you so much. Hello, everyone. My name is Danny Purcell. I'm a member of the Lamouille Lab, and the title of my project is High Throughput Identification of Novel Modulators in Hybrid Epithelial Mesenchymal Transition States. And our reason for studying this project is because of its direct link to cancer. Now, cancer is the second leading cause of mortality worldwide, overall associated for about 10 million deaths every single year. And one of the aspects of cancer that makes this disease so detrimental to the population is its ability to invade and metastasize to secondary sites in the body. In fact, metastatic disease is overall responsible for about 90% of cancer-related mortality. So there's a deep need to understand the driving factors that are pushing a cancer cell to metastasize. One of the cellular programs that we know participates in metastatic disease is epithelial mesenchymal transition, or EMT. Now, EMT is a reversible spectrum of changes that, as the name suggests, occur when an epithelial cell dissolves its cell-to-cell junctions and adopts this mesenchymal phenotype. And this is important because as it does so, it acquires increased invasiveness and resistance to apoptotic stimuli. And these make mesenchymal cells especially well equipped for intravasation into the bloodstream and initial spread to a secondary site. Now, once they get to that site, they must extravasate out of the bloodstream, and this is where the reverse process of mesenchymal epithelial transition occurs, where the cells just go backwards from the mesenchymal state to the epithelial state. So overall, successful metastatic disease by EMT-driven process relies on this inherent plasticity where the cells are able to go forward and back through a series of changes. Now, in studying EMT, there are several markers that we can use to delineate the epithelial state. We have proteins like E-cadherin, ZO1, and cortical beta-catenin. These all signify an epithelial cell. And then on the opposite end of the spectrum, we have the mesenchymal phenotype. And these are symbolized by proteins like N-cadherin, vimentin, fibronectin, and nuclear beta-catenin. There's also changes in protein without changes in protein structure without overall changes in expression, such as the formation of actin stress fibers. So it's relatively easy to say, yes, this is an epithelial cell, and yes, that is a mesenchymal cell. But what about these cells that are in the middle? Well, that's where you want to actually focus, because recent research has found that these partial or hybrid epithelial mesenchymal cells have the highest tumorigenicity when compared to purely epithelial or purely mesenchymal states. They've been found in several in vivo cancer samples and overall related to increased risk of recurrence, higher rates of metastasis, and a poor prognostic indicator. So if we are truly going to treat metastatic cancer disease, these are the cells that we are going to want to focus on. But here comes the challenge, because dual expression of both epithelial and mesenchymal markers makes them difficult to characterize. At what point do we say a cell stops being epithelial and is no longer mesenchymal, but it's somewhere in the middle? So one way of looking at epithelial mesenchymal transition is by conventional immunofluorescence, which we stain proteins and we take a picture of the cell. And by taking several representative images within that in vitro sample, we can say this summarizes the whole. The issue with this is that even in vitro samples, these populations of cells are highly heterogeneous, and you can see there's a lot that's being missed by these pictures here. There's a huge gap, and so that's what we seek to close. So I'm using a device that I'll refer to as the Pico, and this is able to perform automated imaging of the entire well, and at the same time, it allows for analysis of those images that we take. So how exactly does this work? Well, we have a cell, we can stain it for 2 proteins, and we can register the overall intensity of those proteins. And then I can program the Pico based on the analysis that I want to detect several different changes within the cell. So we can look at co-localization, or we can look at loss of expression. We can also look at changes in the conformation of proteins, as well as change in the overall morphology of the cell itself. All of these can be done using an appropriate analysis as long as the Pico can be taught how to do that. And so how did I teach the Pico to do these things? Well, I started with, this is an epithelial cell. And based on the expression of these markers, if there was a high level of intensity, the Pico could reliably say that this cell is epithelial. And we could do the same thing with a mesenchymal cell based on the expression of those markers. And so the challenge here is I want to increase the overlap of these in order to maximize this hybrid cell population, because those hybrid cells are what we want to focus on most. And so in order to do that, I'm working in 3 separate cell lines here: NMUMG, A549, and Hackett. And we have a model where we can reliably induce EMT with this compound transforming growth factor beta, or TGF beta. This is known to push cells into the mesenchymal state. It therefore acts as our positive control. Now, TGF beta can be inhibited by this SB compound. This effectively shuts down TGF beta signaling at the receptor. And so this allows cells to remain in that epithelial conformation. So this is acting as our negative control. And so this brings us to our first model of EMT, which is a treatment-dependent model. And so we're trying to capture the entire spectrum here. And by doing so, or by applying different treatments to our cells, we were hopefully able to see where exactly they fall on that spectrum of EMT. And so first, we're looking at the epithelial marker E-cadherin and this fibronectin, or the mesenchymal marker fibronectin. And remember, SB, we would expect cells to be highly epithelial, which means a high level of E-cadherin. And we can see that being expressed in this image here by the orange stain. Not only can we see that this is being highly expressed, we can see that the Pico is detecting it with this green mask. So it's picking up on this high level of E-cadherin expression. And we would expect the opposite to be occurring with the mesenchymal marker fibronectin. We can see there's very little fibronectin in this image, and that's being shown by the negative red overlay here. These are negative cells. And so this profile switches with treatment of TGF beta. These cells are now mesenchymal. We can see they have high fibronectin and low E-cadherin with that positive fibronectin mask here. And so I want to zoom out because we're doing a whole well analysis. I think that this actually shows the strength of this. So we can see in this first well here, the SB treatment group, all of that E-cadherin that then becomes lost when we treat with TGF beta and we induce EMT. And as we switch to the mesenchymal marker fibronectin, the opposite of true, you have high levels of fibronectin in the TGF beta treatment group. And I think that the strength of this is actually outlined best when we lay this over the spectrum that I've been talking about. So we can see high levels of E-cadherin and low levels of fibronectin in that epithelial state. And as we alter the different treatments that we put on the cell, we can see that the full spectrum is almost reflected in the well. You can see that the E-cadherin expression is lost, the fibronectin expression is gained, but also notice something happening somewhere in the middle. That's what we want to focus on. So I've quantified this data for you here, and I want to draw your attention to this TGF beta plus SB group. These cells actually express a unique population proteome of fibronectin that is distinct from both the TGF beta treatment group and the SB treatment group. So this represents a unique population, and this is where we would expect the hybrid cells to maximally appear. So I can change the way that I represent this data. I can put it on an XY graph with E-cadherin on the X-axis and fibronectin on the Y-axis. And in the SB group, we would expect cells to cluster along that X-axis, and we can see that, in fact, they do. With the TGF beta group, we would expect them to cluster on the Y-axis, and we can see that that's also occurring with high levels of fibronectin. And then somewhere in the middle in that TGF beta plus SB group, that's where we would expect those overlap of cells. And we can see that that's nicely happening here as they form the pattern that you see. So we can take these individual cellular measurements and we can actually put them into a stronger analysis, a principal component analysis. And essentially all you need to understand here is cells that behave similarly cluster together. So we have our TGF beta treatment group or our mesenchymal group clustering over here. And then we have our SB treatment group clustering on this opposite side. It's important that they're opposite of one another, right? Because we would expect them to behave oppositely. And in between them, we have this TGF-beta plus SB group. And so this is the hybrid population. So I can show that just with the treatment-dependent model, I can successfully capture a population of cells that are hybrid in nature, not just mesenchymal, not just epithelial. And so I wanted to further validate that. So we're going to transition from the 48-hour model to a kinetics model. And so this is no longer treatment dependent, it's time dependent. So we're applying TGF-beta at different time points and expecting to find the hybrid population most prevalent in this in-between state, or the 18-hour state. And so here we are looking at the expression of two new markers, but there's still an epithelial marker of Z01 and the mesenchymal marker of cortical beta-catenin. So we would expect Z01 expression to drop as you treat with TGF-beta across time. And we can see that that's the case. So at time 0, you have high expression of Z01 over in this panel, and that's steadily lost as the cells are allowed to incubate for longer periods of time. And the same thing can be seen with cortical beta-catenin. So you have a nicer cortical pattern that is gradually lost as the cells undergo EMT. And so look at what's happening here in the 18-hour time point. We've achieved this stable or partial hybrid population where cells are still expressing Z01 and still expressing beta-catenin. And I've highlighted two particular cells of interest here that might represent hybrid cells, because these cells have dissolved their tight junctions, they've dissolved their organized Z01, but they're still expressing the protein, and they're still expressing some beta-catenin, although it seems to be moving into the cytoplasm. And so this represents us possibly capturing the hybrid cell for the first time in imaging. And I've gone ahead and quantified the expression of Z01 here, showing that the overall population trend is significantly different from hours 24 and hours 12. And I've done the same thing with beta-catenin, showing a nice downwards trend that would mimic what we would expect. So I've now validated this imaging technique in two separate experimental models. I'm going to transition to a third. So moving away from the kinetics model, we're now talking about the reverse MET model. So all of these cells are treated. They're allowed to fully progress through EMT and adopt the mesenchymal state. And then we change the media that they're in and allow them to steadily revert back to the epithelial state. And depending on what we change it to, we would expect them to reach that state at different times. So we can see that cells that are allowed to stay in TGF-beta, these stay highly mesenchymal. They're very spindle-shaped. As we switch to the TGF-beta inhibitor, this SB compound, those cells revert almost completely back to their epithelial state. So we can already see changes in phenotype. And I've gone ahead and quantified that by immunofluorescence. And so we've gone back to E-cadherin and fibronectin with our epithelial and our mesenchymal markers. So the cells that were changed to TGF-beta, you can see there's a high expression level of fibronectin, versus when we switch to SB, there's a low expression of fibronectin here. And the opposite being true of E-cadherin, you can see all of that nice orange in the well that's not really seen in that TGF-beta treatment group. And I've gone ahead and quantified that here with the overall expression with a drop of fibronectin with SB and an increase in E-cadherin with SB. But one thing that I want to highlight to you, which I think really shows the strength of this, is I want to zoom out on this image that I took here. And I just want to show this is the heterogeneity that I'm talking about, even in an in vitro sample. So you can see that if I had just focused on this spot here, all of these cells are essentially epithelial. This is a strong epithelial colony with a lot of E-cadherin. But look at the borders of these. So you can see that extending in between borders, there are cells that express fibronectin. And all of these yellow cells here are cells that are expressing both fibronectin and E-cadherin. So I think this is really highlighting in this one snapshot the full strength of whole well imaging and automated analysis that I've performed here, identifying all of these hybrid cells just in one little picture. So we can further strengthen this with additional changes in protein expression. I'm going to go a little bit quickly through this. So this is N-cadherin. It's another mesenchymal marker that we've used, just showing that we can further validate our experimental design here. We can also look at altered protein localization, because it's not just changes in expression, it's also changes in subcellular localization. So we can look at the protein vimentin here, which is tightly clustered to the Golgi, and then it sort of spreads out and it loses that Golgi interaction. And that's able to be detected by the PICO and able to be quantified by positive-negative overlap. We can also look at changes of cell shape, like the adoption of the spindle phenotype that can be measured by circularity, or the formation of actin stress fibers, like you can see here, being highly cortical and then spreading out to this stress fiber formation. Okay, so we've validated the design. We've picked up on the hybrid. What does all of this mean? So one of the ways that we can apply this to EMT is through microRNA analysis. So we know that one of the ways that EMT is controlled is through various expression of these microRNA molecules. So we performed a screen where we treated cells with TGF-beta, and then we analyzed their expression of several different families of microRNA. And using a similar technique that I've described to you today, we can identify two families of microRNA that change expression based off of their place in the EMT spectrum. So these cells, this highly mesenchymal, they have a high expression of this microRNA 181, showing that this family promotes EMT, and they have a low expression of this microRNA 30. This family inhibits EMT. So we can take these microRNA and we can express them within the cells, and we can show that what we found in our PCR analysis actually is confirmed with the overexpression. So when we overexpress this inhibitor, microRNA 30, these cells remain fairly epithelial. But when we overexpress microRNA 181, the EMT promoter, you can already see these cells are not really connected, and they readily undergo EMT in the presence of TGF-beta. And for those unfamiliar, so with microRNA, I'm inhibiting a large family of genes here. It's not direct targeting of just one gene. We're inhibiting a lot of different genes. And so the way that we would need to narrow down what genes are actually leading to these changes in EMT would basically be by an siRNA-directed library. But this would be very arduous of a task without some form of high throughput or automated imaging, like I've described to you today. And so what we did was we applied a similar technique to what I've been talking about, and we were able to use an siRNA library to detect 15 total genes, 3 of which are shown to be potential EMT inducers, and 12 of which are shown to be potential EMT inhibitors. And I think this highlights where this technique can be maximally applied, because it is readily allowed for identification of novel modulators of EMT. And so that brings us to conclusions and future directions. So in addition to isolating the hybrid population successfully, we've also found new modulators of EMT. All of this serves to strengthen our understanding of the EMT process, and that can allow for large-scale screenings of other factors that contribute to EMT, as well as drug treatment efficacy, screening for several different drugs all at one time to improve the treatment of therapeutic disease. And so that's what I really want to hit home, is that identification of new modulators and a technique like this is overall going to improve our treatment of metastatic cancer. And with that, thank you for listening. I'd like to thank Sammy for all of his help, Dr. Allison Teggy, the Smith Lab, and of course, Dr. LeConte.
All right, thank you so much, Danny. That was great. Questions from the audience?
Good job, Danny T.
Thanks, John.
All right, so in your first data set, I don't know if I missed something. So you have SB and TGF-beta.
Yes.
Giving your, like, are they put on at the same time? Or like, how come?
No, that's a good question.
Okay.
So SB needs to.
I needed your validation.
So SB, I don't think I need to go all the way for this, but SB attaches to the TGF-beta receptor at an ATP pocket. And so essentially the way that works is TGF-beta attaches to the receptor, and then they bond and dimerize, and then they're able to autophosphorylate. So you need to treat with SB first, because it needs to get in and bind to that ATP pocket to prevent them to prevent the ATP from fitting prior to the dimerization. So you treat with SB first for about 10 minutes.
Okay, and like, but then it doesn't keep blocking 100% then after, because you have this where you get your hybrid, right?
It's actually really effective at treating at stopping that cascade. What we think is happening is that there's not 100% uptake in the cell population. So some of them are getting SB right away, and they're allowing that full 10 minutes of incubation. Some might get it without that full 10 minutes of incubation. Some might not get it at all. And so I think that's where it's being reflective of the spectrum, is that there's just differences in uptake within the cells in the well.
Okay, and like biochemically, you wouldn't see that, right? I think it would just biochemically, it might just look like a complete block.
If you were doing a Western blot, yeah.
Okay, great job.
Thank you.
Any other questions from the audience? All right, great talk. Thank you.
Thanks.
Next, we're going to hear from Kelly Ingram, who worked with Dr. Brittany Howell from FBRI. So many of you know Kara Spivey, and Kara Spivey says that Kelly Ingram is the shiniest of stars. She did an amazing job. You're going to see some fabulous results here, a lot of data that was collected, and Kelly really did, a lot of this single-handedly. Recruiting, screening, consenting, over 70 participants, I think, and, all on her own as she's, doing the life of a medical student. So keep that in mind as you hear from Kelly about her research.
Thank you. I'm Kelly Ingram, and my project is the impact of obesity on the perinatal vaginal environment and bacterial microbiome with effects on birth outcomes. So to give a little bit of background on the vaginal microbiome, it's primarily composed of lactobacillus species. These help maintain a normal acidic pH of less than 4.5. When dysbiosis occurs, we see overgrowth of other bacteria or yeast, as well as an increase in pH. One of the big regulators of the vaginal microbiome is estrogen. So that promotes the deposition of glycogen in vaginal epithelial cells. When those cells lyse, they release the glycogen, which are used as a fuel source for those lactobacilli. They produce lactic acid, which lowers the pH, as well as inhibits the growth of other microbes. So our next question was, what do we actually know about the vaginal microbiome in pregnancy? Well, we do know that hormone levels like estrogen and progesterone will increase throughout pregnancy. And we also know that the vaginal microbiome diversity decreases, so we get more of those good lactobacilli. But we didn't really know what role that obesity played in this. In some studies in non-pregnant obese people, we see greater diversities of vaginal bacteria. We see higher vaginal pHs, as well as an increased risk of dysbiosis. In obese pregnancies, we see lower circulating estrogen levels from decreased placental production, and we also see increased risks of things like miscarriage, preeclampsia, and preterm birth. So our overarching question was, what is the relationship between the vaginal environment and microbiome and obesity with pregnancy progression and outcomes? So our hypothesis was that our overweight and obese participants will have decreased circulating estrogen levels, which means there'll be lower vaginal glycogen levels, less of those good lactobacilli. They're not producing that lactic acid, so that level will be lower. We'll see a higher pH. We'll also see more diversity in the bacteria, which is an increased risk of infection, and these things will lead to negative pregnancy outcomes like preterm birth. So our aims were to first identify individual changes in these measures, estrogen, glycogen, pH, and microbiome diversity throughout pregnancy, and then define patterns in those measures to predict pregnancy outcomes. So in our original calculation, we wanted a sample size of 63. We divided those into 3 groups based on pre-pregnancy BMI. So we had 21 healthy weight, 21 overweight, and 21 obese participants. We decided on a longitudinal study design so we could collect samples at 10 to 14 weeks, 18 to 24, 26 to 30, 34 to 37 weeks, and also at the time of delivery. So we could monitor changes in those variables over time, as well as look for differences between our groups. So in the recruitment process, we screened a little over 1,000 participants based on our inclusion/exclusion criteria, which included things like a previous C-section, any history of hypertension or diabetes, as well as no antibiotic or probiotic use within the past 3 months. A little less than 300 of those people were eligible. We ended up recruiting 72. We lost 3 to follow up. 1 moved out of state and 1 had an early miscarriage before we collected any samples. So we ended up with 23 healthy weight, 22 overweight, and 22 obese participants. Our participant demographics were fairly similar across all of our groups. Ages ranged from 19 to 42, the average age of 29. Most of our participants were Caucasian, had higher levels of education, as well as higher yearly household incomes. Most were married or in some type of relationship, and for a little less than half, this was their first pregnancy. As far as total samples collected, we collected 61 estrogen samples at the 10 to 14 week time point. And then for our vaginal pH, glycogen, and microbiome, we collected about 300 samples over our 5 time points. The birth samples were collected by our OBGYN residents at the time of delivery. And then we also got an infant oral and skin microbiome sample so we could look at transfer of bacteria from our participants to their babies. So our first variable is our total serum estrogen. And here we ran into a couple of issues with our assay. Originally, we wanted to do estrogen samples at each of those time points as well. But the radioimmunoassay offered by Quest had a maximum quantification of 4,000 picograms per milliliter, which we did not know at the beginning. And we knew that estrogen samples were just going to continue to rise throughout pregnancy. We wouldn't see any meaningful results later on. So this is just representing the 10 to 14 week time point here. And since we had data censoring with that upper limit, we did a log rank test that did not show any significant differences between our groups. But you can appreciate for our healthy weight group, most of our samples are clustered around that 4,000 upper limit, whereas with our overweight and obese group, you see more variability in those groups. So if we had a different assay that didn't have that upper limit, we might be able to show some more meaningful results there. Then for our vaginal pH, we used these little Hydrion pH strips. We did a linear mixed effects model here that didn't show any differences between our healthy weight and overweight group, but we did see a significant difference between our healthy weight and obese group at the 10 to 14 week time point. So the big takeaway here was that our obese participants had an elevated vaginal pH early on in pregnancy. Then for our vaginal glycogen, here we did a fluorometric glycogen assay kit. We also did a linear mixed effects model. We didn't see any differences between our groups here, but we did see a significant increase in the glycogen concentration in our obese group over time. And this is potentially a compensatory mechanism in order to alter the microbiome. If we're increasing the glycogen, we're providing food for those lactobacilli so they can thrive. And then we have our microbiome alpha diversity, and this it describes how diverse the sample is. We use a Chow-1, which is a measure of bacterial richness, which is basically like a count of the bacteria that are present. It's really good for skewed samples like ours that were mostly lactobacilli, so we can account for all the other bacteria that are present. Again, we used a linear mixed effects model. We didn't see any differences between our healthy weight and overweight group, but we did see a significantly higher alpha diversity in our obese group compared to our healthy weight group. And then if we look at birth and infant outcomes, most of our participants did deliver vaginally. For our healthy weight group, all of them delivered at term. We had 2 in our overweight group and 3 in our obese group that delivered prematurely. Unfortunately for our participants, but unfortunately for us, there weren't many pregnancy complications. So instead of looking at complications individually, we decided to look at pregnancies as a whole and included participants with 1 or more pregnancy complications in our complicated pregnancy group. And the number of participants with 1 or more pregnancy complications was 2 in our healthy weight group, 10 in our overweight, and 9 in our obese group. So if we look at our variables, comparing the complicated and uncomplicated pregnancies for pH, glycogen, and alpha diversity, we didn't see any significant differences between these groups or changes over time. And this could possibly be due to our low sample size. We only had 21 complicated pregnancies. So if we had a bigger study with more of those complicated pregnancies, we might be able to show some significant results here. So that's why we needed to take a closer look at our vaginal microbiome. So this is the bacterial abundance of by group, and we removed lactobacillus since that was the primary bacteria present in all of our samples. So we can kind of see what's left over. And then if you look at our 10 to 14 week time point for each of our groups, that's where we really see the biggest difference. We have a lot of non-lactobacillus organisms in our overweight and obese group compared to our healthy weight group. So if we look at lactobacillus, here we see a higher relative abundance in our healthy weight group compared to obese group. And this predominance of lactobacillus was expected across all of our samples. However, if you look at our healthy weight group, the median relative abundance is nearly 100%, whereas for our obese group, it's close to 80%. So that really helps support our hypothesis that we're seeing less of these lactose in our obese population. We also identified a couple other bacterial genera, Peptinophilus and Anaerococcus, that were in a higher relative abundance in our overweight and obese groups compared to our healthy weight groups. And both of these are anaerobic gram-positive cocci. They're found in many different body sites, and they're also implicated in many different types of infections, including chorioamnionitis and ovarian abscesses. So there's some type of retrograde movement of these bacteria up the reproductive tract, and they have an ability to cause these types of infections.
If we look at bacterial abundance based on pregnancy complications, we have our complicated versus uncomplicated pregnancies here. And again, we see the biggest differences early on in pregnancy with more non-lactobacillus organisms present in our complicated pregnancies. And then we also see a return of our friends Peptonephilus and Anaerococcus, which were also in higher relative abundances in our complicated groups compared to our uncomplicated groups at 10 to 14 weeks, as well as 18 to 24 weeks. So as far as conclusions for our vaginal microbiome, we saw the greatest differences in our variables between that 10 to 14 week time point. The composition of the vaginal microbiome in early pregnancy may play a larger role in pregnancy and pregnancy complications than we originally realized. Being able to predict those negative pregnancy outcomes early in the first trimester will have the highest potential to allow for interventions and potentially alter clinical practice. But essentially, we're laying the groundwork for a bigger study where we look into screening pregnant women for these risks or even altering the vaginal microbiome to prevent those negative pregnancy outcomes. So now let's take a look at the newborn microbiome. So this is the skin microbiome by group. And unlike our vaginal samples, we see more skin type bacteria here. So we see our Corynebacteriums. And as far as comparing the different groups, we see very similar bacteria across the groups. But you will notice that for our obese group here, we have this nice big purple chunk, and that's Peptonephilus. So Peptonephilus was found in higher abundances on the skin of our newborns born to obese participants compared to the healthy weight ones, and this could potentially increase their risk of infection. And then if we look at the skin microbiome based on delivery method, comparing C-section versus vaginally delivered newborns, we see more diversity in the bacteria present on those vaginally delivered newborns, which is also highlighted in a comparison of our alpha diversity here with a higher alpha diversity in our vaginally delivered babies. We also identified a couple other genera, including the Burkholderia and Allerhizobium genus that we saw in higher relative abundances in our C-section babies compared to our vaginally delivered ones. These are both gram-negative bacilli. They're environmental opportunistic pathogens. For Burkholderia, increased relative abundances found on the skin have been associated with elevated IgE antibody levels, as well as the development of allergies. And then for the Allerhizobium, we find higher relative abundances of these bacteria on the skin of patients with psoriasis. So there's some type of inflammatory component going on with these particular bacteria that could potentially put these babies at risk of development of other inflammatory conditions like allergies and autoimmune diseases. And then we also identified Prevotella, the higher relative abundance in our vaginally delivered newborns compared to C-section ones. And this is an anaerobic gram-negative bacilli, typically found in many different body sites. Overgrowth of this bacteria can result in bacterial vaginosis, but as far as our newborns go, it's really important bacteria for helping to seed the skin, the oral cavity, the gut, and help their microbiome develop. And then for our oral microbiome, this one was primarily lactobacillus again, so we removed that so we can look at what's left over. And this chart just has the most satisfying little stair step between our healthy weight, overweight, and obese group, but the bacteria here are fairly similar. The differences we found were a higher relative abundance of Bacteroides and Ruminococcus in our obese group compared to our healthy weight group. And these are both major gut microbiome bacteria. For the Bacteroides, there's a lot of controversy around this subject, but there is some evidence that supports higher abundances of this bacterial genus in infancy could be associated with the risk of developing obesity. And then for Ruminococcus, higher gut abundances in early life have also been associated with the development of allergies. And then if we compare delivery method, so this was probably the most surprising thing we saw in the whole study, because normally you would expect that the vaginally delivered newborns would have a greater variety of bacteria present, just like we saw on the skin, but we didn't see that in this case. The only difference we saw was increased uriplasma in the oral cavity of C-section delivered newborns versus vaginally delivered ones. And this is typically found in the urogenital microbiome. It has been known to colonize amniotic and placental membranes. It's also been associated with a risk of preterm delivery as well as many newborn infections. And what's interesting is that uriplasma was present in the vaginal samples of our participants whose babies were colonized, but the relative abundance was less than 3%. And I think this speaks to this bacteria's ability to gain access to the reproductive tract and thrive in such close proximity to the baby. So in terms of conclusions for our infant microbiome, we've identified some differences based on pre-pregnancy BMI as well as the method of delivery. These differences could be linked to things like allergies, autoimmune diseases, and infections. But again, we're laying the groundwork for future research into potentially altering the vaginal microbiome, which will have a major impact on the newborn microbiome as well. So that's something that we have to keep in mind if we move forward with this research. And then as far as future directions, we've assembled data that speaks to the feasibility and importance of assessing the vaginal microbiome and during pregnancy to identify women at risk for weight-related pregnancy and birth outcomes. In the context of a larger study, we can further assess the importance of the vaginal microbiome in early pregnancy and gather more data on those target bacterial genera like Peptonephilus and Enterococcus and their relationship with pregnancy outcomes. And if we're able to identify and remove sources of risk, meaning that dysbiosis, we have the potential to reduce the burden of complications faced by these patients and their newborns. And I just wanted to thank everybody who was involved in the study, Dr. Howell and everyone in her lab, Dr. Nunziato, Dr. Teggy, Dr. Ahrens, Kara, Imbel, as well as all of our OB residents, iThrive for giving us a grant so we could sequence all those samples. And then of course, all of our participants who we couldn't have done it without. Any questions?
Thank you so much, Kelly. It looks like we have somebody heading now for some questions.
Hi, Kelly.
Hello.
First of all, amazing presentation. And then I have two questions. My first is, this was a huge undergoing, and I was wondering what was the most difficult part of your project?
Yeah, I think probably the most challenging thing was coordinating all of the sample collections between all of our participants that were involved because we tried to make it as easy as possible so they didn't drop out of the study. So we would deliver the sample kits to their house, they'd collect them, and then bring them into their prenatal visits that were already scheduled. So we were kind of working around their schedule to make it easy to get our samples. So doing that for 67 people is quite the undertaking.
Thank you. And my second question is, how do you see your research clinically impacting future women? Like, what does that look like? Does that look like vaginal probiotics or like what?
Yeah, we've been throwing around a couple different ideas, either oral or like suppository vaginal probiotics. We've also been talking about potentially like glycogen suppositories as that would act as like a prebiotic for the bacteria. But that's kind of way down the road from now. We need to do a bigger study where we're kind of looking at the bacteria before we try and intervene.
Thank you.
You're welcome.
Hey, Kelly, great job.
Thank you.
Two questions as well. I guess the first, just kind of speculation out of interest. Any ideas on like the mechanisms between the increasing complications and some of the increased criteria that you saw when comparing your groups?
Yeah, I think the biggest thing would be those particular bacteria's ability to cause inflammation and infection. So like Peptonephilus is a very sticky bacteria. So its ability to kind of proliferate in the vaginal cavity, as well as its ability for retrograde movement into the uterus can potentially cause those pregnancy complications that we see leading to things like preterm birth.
Cool. And then kind of second question, I think with the microbiome, you're dealing with so many different bugs. And so when comparing groups, I imagine you kind of run into issues with multiple comparisons. And so I was kind of wondering how you best address that when like do you decide like before like what bugs you're going to specifically look at, or you kind of just go, take things in stride and see what you get?
Yeah, so since this was a pilot study, we kind of just looked at everything all together, and we talked about potentially doing multiple comparisons in our statistical analysis, but eventually we just ended up not doing that. I think if we had a much bigger sample size, we would be able to do that. But really here, we were just trying to identify potential sources of risk for these women.
Cool. Thank you.
Yeah.
Fantastic presentation. I wanted to follow up a little bit on that in terms of abundance versus diversity in the microbiome. So I was curious, just in kind of some of the sample analysis that you all did you think, why did you target abundance versus diversity?
Yeah, so I think the reason that we went more towards abundance later on was because when we were looking at the complicated versus uncomplicated pregnancies, we didn't really see a big difference in the abundance in the diversity of the samples when we were comparing those two groups. So that's why we kind of went down to a more micro level to see if we could identify any differences. And that's when we found the peptinophilus and the Anaerococcus.
And lastly,
Yeah.
is there a connection between a higher BMI and potentially core body temperature or vaginal basal temperature that could potentially play a role in the microbiome environment?
Yeah, I mean, I don't have any specific information or data on that, but I'm sure that it has some impact because the different temperature would allow for different bacteria to thrive. So I think that could definitely be a factor, but it's not something that we looked at in this study.
Fantastic presentation.
Thank you.
Thank you so much, Kelly.
All right, we're going to move to rapid fire presentations. So remember, we're going to have several students, 4 students present back to back, and then we'll bring all of them up at the end. So keep your questions in mind, write them down, put them in your phone, and then come up to the mics and ask them afterwards. So our first rapid fire of this session will be from Sam Speroni, who worked with Dr. Emily Fox and Dr. Brian Collier in the Department of Surgery. And this is another study in which the student being hands-on doing the data collection was essential to it actually getting done. And I think maybe she learned some ultrasound along the way.
All right, thank you so much. So my name's Sam. I'm going to be talking to you about our project, which uses lung ultrasound to predict clinical outcomes in patients with chest wall trauma. So just a little bit of background. Patients admitted to the ICU, specific trauma patients with chest wall trauma, have a high rate of respiratory complications. And in fact, when we did initial analysis on the patients in our ICU with chest wall trauma, we saw there was about a 25% complication rate in these patients. And this includes things like development of pneumonia, ARDS, or unplanned intubations. And so we know that imaging is often used as a prognostic tool in the ICU, specifically because we know that really sick patients, sometimes the vital signs are not a good predictive tool. And so something like ultrasound can be used to help figure out which patients are going to help develop complications. And so bedside lung ultrasound is a cheap, fast, and appropriate way to help monitor these patients. And specifically, some studies have even said that these can have greater diagnostic accuracy than CT or chest X-ray, which are commonly used. So just to talk about a little bit more about lung ultrasound, we use 3 main things to help us diagnose lung pathology. There's first would be A lines, and just for simplicity's sake, we'll say this usually indicates normal lung. B lines, and especially when seen in multiples, usually indicates lung pathology. And then lung slide, which I think is best depicted in this video here, looks like a shimmering artifact, usually from respiration. And if you don't see this shimmering artifact, usually this indicates a pneumothorax or a collapsed lung. And so our research question was, can serial point of care lung ultrasound findings predict worsening clinical conditions in traumatic chest injury patients in the ICU? And we hypothesized that patients who develop respiratory complications should show an increase in the number of B lines that they have from a 0 to 24-hour time point to a 48 to 72-hour time point. And so just to go over the workflow of our study, so we recruited patients 18 years or older with chest wall trauma, and these included things like ribs, sternal, and clavicle fractures, as well as pulmonary contusions. They had to be admitted to the ICU for these injuries, and we got a scan at 0 to 24 hours and quantified things like A lines, B lines, and lung slide. We got a second scan at 48 to 72 hours of their admission and quantified these same measurements. And then every 24 hours up to ICU day 7 if they stayed in the ICU. We then reviewed images with at least 2 blind reviewers for joint consensus on quantification of these measurements, and also collect things from the EMR like accessory muscle use, ABGs, and other things to compare later. Also to mention that the points that we use when we do these ultrasound, this is from the Blue protocol, and this is a well-established diagnostic protocol for using bedside lung ultrasound. And also for patients that had these 2 scans, it was a requirement to be included in the study. So if patients did not get these 2 scans, then they would be excluded from our final analysis. And so here's some recruitment data. So as you can imagine, it's kind of laborious to go in and get all of these scans. So initially we scanned about 65 patients. Good for the patients, bad for us, but 45 of them were downgraded from the ICU, such they were no longer eligible for our study. So ultimately we had 20 patients who had 2 scans, which means they qualified for our final analysis, and a few more that stayed up to ICU day 7, ultimately resulting in 108 scans total. This is some preliminary analysis, which shows that the first 20 patients in our study, as you can see, we have a number of patients who develop complications, and it shows the change in the number of B lines. As you can see, the orange is the patients who had a decrease in the number of B lines. Green is the patients who had an increase in the number of B lines. And there's also, when you're looking at the complications, there's really no clear pattern to whether patients are going to have an increase or a decrease. Some of this can be due to a lot of factors that are not accounted for just in the imaging alone, but also just power of our study. So another thing I want to note is that when we did our initial analysis in 2020, we had a 25% complication rate. And based on our first 20 patients that we recruited in this study, we had a 35% complication rate. So this is actually higher than expected. And here I just want to show an example of what we're looking at when we have this B-line quantification. So this is a patient who was presenting with rib fractures. They had transfusion-related lung injury. And here we would quantify this as 3 B lines because they have 3 kind of comet-tailed artifacts originating from 3 original points. And this is a scan at 48 to 72 hours. And this patient has only 1 B line. And so this patient had a decrease in the number of B lines from point A to point B. And so just to wrap it up with some conclusions discussion. So we saw that complication rates were higher than expected in our patient population. We also saw that B-line quantification is a very dynamic process. 16 out of the 20 patients that we recruited had a change in their B-lines from point A to point B. And lastly, in this situation, B-line quantification in lung ultrasound is used more as a prognostic tool, not necessarily a diagnostic tool. And so some things for future directions is we just want to continue collecting data. We hope to build an algorithm for prognosis, including some of those other clinical endpoints that we included in the EMR, and also just continue to possibly start scanning patients out of the ICU, all those patients that we essentially lost to follow-up. If we could get data collection on them, we would have ability to better capture those patients who clinically improve. And so just some acknowledgements. This is our team. I just want to thank Dr. Emily Fox, who's been an amazing mentor to me, both in research and just in my own personal endeavors, as well as all of our fellows who helped us collect data. And I'll take any questions after everyone else presents.
Thanks, Sam. Our next presenter will be Casey Engel, and she worked with one of our VTC alums, Dr. Josh Eichenberg, who was here for a little while, but now is in Hawaii, and Dr. Zachary Holcomb. So she's going to present a study that I tell many of you, if you're going to do clinical research, a lot of the work happens up front, and the hardest part of clinical research is communication. And Casey showed top-level communication skills. So the study design is clean and simple, and getting there, I would say, was not. So let's hear from Casey about her study.
Hi, I'm Casey. I will be presenting my research on a double-blind randomized pilot study to investigate the thermosensitivity of a topical palmitated formulation of capsaicin. So capsaicin is the active component of chili peppers, and it's been found to be an effective topical for pain management. It's found in a lot of over-the-counter formulations that you can find at your local drugstore. But unfortunately, although it works for pain, it is limited by its associated burning sensation. So patients are often unable to tolerate it and don't end up using it, even though it works. And so our question was, how can we make topical capsaicin a more tolerable treatment for pain? So the proposed mechanism in which we wanted to do this was by adding a palmitic acid group to make the capsaicin molecule nonpolar and neutralized. This would allow it to be gradually hydrolyzed in the dermis, leading to reduced burning sensation. Our aim was to provide evidence for optimized tolerability of palmitated capsaicin, which is our study drug, compared to non-palmitated capsaicin, which is the original over-the-counter standard version. Our primary endpoint was burning sensation, and our secondary endpoints were erythema, which is kind of redness, or pruritus, which is itchiness. We hypothesized that the administration of palmitated capsaicin would produce decreased burning sensation compared to an even lower concentration of non-palmitated capsaicin, the standard formulation. This is our methodology. We recruited 52 healthy volunteers through the Carilion Clinic Dermatology section. We had a pre-pilot study of 8 patients, just comparing our 2 controls, the standard non-palmitated capsaicin and then a placebo cream, and this was done to determine the risk of adverse events. We then moved on to our next 44 subjects and randomized them into one of 3 groups, comparing our 3 different drugs, palmitated capsaicin, non-palmitated capsaicin, and placebo. We then assessed patients for 1 hour following study drug administration and assessed parameters such as burning pain, redness, itchiness, etc. every 10 minutes using a visual analog scale. We then analyzed these scores for between group differences using a linear mixed effects model in R. And here are some of our results. So you can see in the red is the standard non-palmitated capsaicin that you can get today at your local drugstore. And then in the green, you see palmitated capsaicin, our study drug. And you can see that its burning profile is much more similar to placebo cream than it is to non-palmitated capsaicin. So the average maximum burning sensation that our patients experienced from our study drug palmitated capsaicin was 0.83 on a scale of 0 to 10, compared to an average maximum burning level of 3.59 from this current standard. And here you can see that burning sensation over that 60-minute period as well. You can see that non-palmitated capsaicin, the standard formulation, has a statistically significant increase in burning sensation compared to our study drug palmitated capsaicin and placebo. You can see that palmitated capsaicin is much more similar to placebo again, and doesn't peak the way that palmitated or non-palmitated capsaicin does. Also importantly, at the 24-hour follow-up, none of our patients receiving palmitated capsaicin had any burning during those 24 hours, whereas almost half of patients receiving the current standard had burning sensations during those 24 hours after administration. So that's pretty significant when half of patients are still having burning in a day after study drugs. So that's definitely something that we were happy to see. We also saw reduced erythema. So the patients that received palmitated capsaicin and placebo had much lower levels of redness where we put the cream, as opposed to the redness that you see here that patients experienced with the standard formulation. They also had no statistical differences in itching, tingling, freezing, or soothing scores. And here you can see a little bit more of that. You can see that non-palmitated capsaicin did have an increase in itching compared to the other formulations, but that wasn't statistically significant. So in conclusion, we saw that palmitated capsaicin has significantly improved tolerability and decreased burning sensation compared to the current standard non-palmitated capsaicin. These results underscore the potential for palmitated capsaicin to improve the tolerability of topical capsaicin formulations, and paving the way for our next steps to explore if it's as effective in treating pain. I'd like to give a big thank you to Dr. Eichenberg and Dr. Holcomb, my amazing mentors, Dr. Aaron and Dr. Teggy for helping with all statistical analysis, and then Dr. LeConte, Kara, and Embel for everything in between. So thank you all, and I'll take questions at the end.
All right, next we're going to hear from Ilana Kate. She had a number of different mentors. So again, a lot of logistics went into planning this project, but Dr. Violet Borowitz was from pediatrics. Dr. Ali Rohani is currently at the University of Utah. Dr. Josh Morales is Blue Ridge Cancer Care. Dr. Tom Diller from Virginia Tech. Dr. Jennifer Vaughn, who used to be here but is now at Ohio State University. So a large team, and again, an immense amount of logistical and coordination. And Ilana was really key in sort of laying the groundwork for good working relationship and streamlined communication with Blue Ridge Cancer Care in particular. So we're excited to hear about her novel device design.
Thank you, Dr. LeConte. So my name is Ilana, and I'll be telling you about my study on sickle cell disease and blood flow. So I'll start with a brief background on sickle cell disease. This is a genetic hematologic disorder characterized by mild to debilitating pain and organ damage. These debilitating pain crises are also called vaso-occlusive crises, and they can be mitigated if they're identified early on. But unfortunately, we don't have a good combination of clinical and lab findings that can determine whether an individual is or is not actually in pain. Right now, our gold standard for pain assessment is the patient's report. And so unfortunately, patient pain is often undertreated due to physician misperception of these patients as drug seeking, and this can lead, as you can imagine, to a large level of mistrust. So as you can imagine, we have a need for a reliable biomarker for pain and the onset of these vaso-occlusive crises in sickle cell disease, as this would empower patients to seek treatment, allow them to self-monitor their symptoms, and increase provider understanding of the disease. We think one such biomarker is perfusion limitation, also known as just blood flow limitation. This is something we know is occurring in patients with sickle cell disease, but there's no good way to actually measure this in real time, easily and non-invasively. So Dr. Rokhanisad, he has developed the ThermoSense BioHeat perfusion sensor, and we think it may be able to measure this perfusion in real time. And so that brings us to our research question was, is there a predictive biomarker for pain and onset of vaso-occlusive crisis in sickle cell disease? And our hypothesis, it's kind of long, but bear with me, adults with sickle cell disease as compared to healthy adults will have higher baseline perfusion, a longer time to return to baseline perfusion, and a longer time to reach maximum perfusion after an occlusion reperfusion maneuver is performed. And the thought with this is that after repeated pain crises, sickle cell disease patients are collecting damage to their blood vessels that can affect their blood flow. And we chose to look at these factors based on a similar study that was done at the NIH. And so just to reiterate, we are going to be obtaining perfusion measurements using the benchtop sensor during an occlusion reperfusion maneuver to establish differences in perfusion between sickle cell disease groups and healthy groups. And so the maneuver, we started with a feasibility study just to kind of test the maneuver itself and also test the ability of the sensor to measure, pick up on measure differences in perfusion. And so then that brought us to phase 2, and I'll explain this maneuver. So basically we had the sensor on the forearm, and then we applied a blood pressure cuff. And then we measured baseline perfusion, which was one of the portions we're looking at in our hypothesis. And then we slowly inflated the blood pressure cuff until we completely cut off blood flow. And then we allowed for reperfusion by releasing the blood pressure cuff. And that's where we measure the other 2 portions of our hypothesis, which was time to maximum perfusion. And so the thought is that when you cut off blood flow completely, you're actually going to have an overshoot in your perfusion. So we're looking at the time to get to that and to return to baseline. And so this is a representative sample from our phase 1 feasibility study. As you can see here, this is the sensor and how it's measuring throughout our maneuver. And so you can see with the green, we have our baseline perfusion, and then we have occlusion beginning at 360 seconds, and you can see perfusion goes down at that point, and then we allow for reperfusion here at the orange arrow, and you can see it goes back up, and then we overshoot into our maximum perfusion. Phase 1, we didn't focus as much on return to baseline, so that's why you're not seeing some return to that. We, in phase 1, also saw a 35.21% average decrease in perfusion throughout the maneuver, so that's why we went ahead with phase 2. And so recruitment is ongoing for this portion of the study. Sickle cell patients are not as easy to find in Roanoke as we would have thought, but preliminary results are trending in our hypothesized direction, not statistically significant at this time. But we are showing that sickle cell disease patients are showing a higher baseline perfusion. They're also showing that they're taking longer times to reach maximum perfusion. Again, not statistically significant at this time. And it's also showing that it's taking them longer to return back to their baseline. We did of note have several patients that really never did make it back to baseline, which was also something to note. And so preliminary conclusions and discussions, ultimately in phase 1, the sensor did show that it's capable of picking up these changes in perfusion, which is very exciting. And in phase 2, though, while it's not statistically significant right now, it is trending in the hypothesized direction. And then another interesting kind of novel finding was that we are seeing increased peripheral perfusion at baseline in these sickle cell patients, whereas previous studies have shown decreased peripheral perfusion. So it's interesting in that, is there some kind of compensatory vasodilation or increase in blood flow when these patients are not in vaso-occlusive crisis? So that's something we'd really like to kind of look into in the future. And then future directions would be to complete the study. And we'd also like to further analyze by their sickle cell genotype and then the severity of their sickle cell disease. And then ideally long-term would we have a kind of wearable form of the sensor and actually monitor these patients at home and have them kind of track pain and perfusion together. And so I'd like to acknowledge my research team, large, but has been so wonderful over the last 4 years. And also big shout out to Kara and Embel for all of their help. They have been my heroes. And so thank you very much.
All right, our last talk of the day is going to be Martin Barilak, who worked with Dr. Robin Queen. And I've talked with or communicated with Dr. Queen a little bit ago, who had a lot of great things to say about Martin. He's been a great member of the lab, and he's asked great questions and worked very hard to understand a project and concept that is challenging and required him to gain an understanding of biomechanics and engineering. So what sitting at the junction between clinical work and engineering, I think is just a great way to end our talks today. So Martin, why don't you come up and give us a talk?
Awesome. Thank you for the warm introduction. Yeah, I'm really excited to share this study. It's assessing dynamic stability using margin of stability in patients with end-stage ankle arthritis and following unilateral total ankle arthroplasty. Get right into the background here and set the stage. Falls are the leading cause of fatal and non-fatal injuries of people 65 years of age or older. An older adult dies from a fall every 19 minutes. And there's a lot of problems that contribute to falls. Some of these include osteoarthritis, unstable foot and ankle joints, and pain. End-stage ankle arthritis affects about 1% of the world's population. There's 50,000 new diagnoses every year. And this is the leading cause of disability in the United States. And so we know that there's some correlation between falls and end-stage ankle arthritis, but why and how this happens from a biomechanical standpoint is not really well understood. Total ankle arthroplasty is one treatment option for these patients with end-stage ankle arthritis. It involves removing the distal tibia on the proximal talus and replacing it with a prosthetic, like in this picture here. And what we're looking at in this study is an outcome, a metric called margin of stability. And to understand margin of stability, it's important to understand base of support and center of mass. Your base of support is the area around the outside edge of the sections of your body in contact with the ground beneath you or the surface beneath you, as shown in this image here. Center of mass is the average parts of all parts of a system, weighed according to their masses. And then our extrapolated center of mass is when a velocity vector is applied to that center of mass. So that gets us to margin of stability. And this is what we're looking at in this study. This is the minimal distance between the extrapolated center of mass and an individual's base of support. So in this diagram here, the blue diamond represents an individual's extrapolated center of mass. And then the red arrows represent the edges of their base of support. And so that distance can be measured in the anterior posterior direction, the AP margin of stability here, or the medial lateral direction, the ML margin of stability here. And this can be looked at through different stance phases. So heel, strike, mid stance, or toe off. So what are we trying to do through this project was to really assess the stability using margin of stability in patients with end-stage ankle arthritis by comparing them to healthy controls, and also look at the stability or margin of stability in patients with end-stage ankle arthritis after total ankle arthroplasty to see how that procedure may or may not affect their stability. This was done using a 3D motion capture system. We had our patients walk barefoot on level ground at a self-selected pace. And that got us our data. We had 50 patients in our end-stage ankle arthritis group that were matched with 50 healthy controls. And then we had 148 patients in our end-stage ankle arthritis, in our total ankle arthroplasty group. And they underwent the procedure and then had 1 year and 2 year follow-up data. This is what we found. So looking at heel strike, we found that the non-arthritic limb of that ankle arthritis group was significantly less stable, had a lower margin of stability than the arthritic limb and the limbs of healthy controls in that anterior posterior direction, and that there was no significant interactions in the medial lateral direction at heel strike. Then at mid stance, we found that the arthritic limb was significantly more stable or had a greater margin of stability than non-arthritic limbs and the healthy control limbs in the medial lateral direction, with no significant interactions in the anterior posterior direction. When looking at how the TAA procedure affects stability, we see that postoperatively, the margin of stability is significantly greater or increased on that non-arthritic limb at 1 and 2 years postoperatively compared to pre-op at heel strike in the anterior posterior direction and at mid stance in the medial lateral direction. So that procedure did have an effect in improving the stability of these patients by 1 year and 2 years postoperatively. So what do we make of these results and why did we find what we found? We postulate that at heel strike, since these patients are in so much pain, they have a more anterior center of mass when they're transitioning from that arthritic limb to that non-arthritic limb to avoid pain on that side. And then when they get to mid stance, they might have a more medial center of mass during single limb support. This is a pattern that's been observed in some other fall prone patient populations, such as older adults or some patients with neurological diseases. And then why might we see patients having a greater margin of stability on that non-arthritic limb after this surgery? We think that surgery decreases a lot of compensatory behaviors on that side. So decreasing that compensation on that non-surgical side makes that non-surgical side more stable, which the patients were unable to do when they were arthritic and before that procedure. This project is certainly not without limitations. It's very difficult to account for all the factors that play into balance and falls. Also in terms of generalizability, level walking at self-selected pace is probably not the most what causes falls typically in these patients. So that could limit our generalizability. And then we had some sensitivity limitations in terms of ground reaction forces and center of pressure and how they play together. Some of our future directions can certainly target those limitations. I think it'd be interesting to mimic some of these conditions that could contribute to falls, like changing directions or changing pace or adding obstacles. It'd also be interesting to look at the clinical utility of margin of stability. It could potentially be used as a fall risk assessment, as part of an outcome evaluation, part of tracking rehab progress, surgical planning, et cetera. Future studies could also look at variations in margin of stability and see how those might implicate balance and fall risk. And I think it'd be also interesting to look at this margin of stability metric in ankle fusion and compare it to ankle arthroplasty or ankle replacement, and to see how these two surgical outcomes, to see how these two procedures affect balance or stability differently. I definitely like to thank you all for listening and thank you all for your attention. I'd like to thank all the participants who participated in the study. I know everyone that's come up here said that they have the best research mentors, but they're all liars because I have the best research mentors. And Dr. Queen and Dr. Reno, I want to thank them for all of their guidance, mentorship, and patience with me as I tried to understand this project. And then my fellow classmate, Stephanie Hamlin, who's been instrumental in also helping and support this project. Thank you all.
Much. If we could have our last 4 rapid fire speakers come down so we can get questions. And I want to open the floor up for questions for these fabulous speakers.
I have a question for Martin. So I think men and women have different center of gravity, different center of mass. I was wondering if you looked at that at all or took that into account when you were kind of designing the study.
Yeah, that's a great point, a great question, Carney. I think that's something that we did analyze. Our patient populations were split pretty evenly with males and females, and that's a covariate that we looked at, and we didn't see a huge effect on the margin of stability metric particularly. But I think that's a great point to make, and it'd be interesting to look at other metrics as well that could impact your center of balance.
Thank you.
Mhm.
I have a question for Sam. It's an easy one, don't worry. I was just wondering, so a couple of different people, not just you, have scanned your patients, and kind of knowing my knowledge, you much better at ultrasounding than I am, but is there a variability amongst different scanners with like the number of B lines that you're seeing? I know there's not a huge difference in some of the patients, and the B line increase or decrease just by 1 or 2. So do you think there's some variability there with different scanners, and or do you think that's not really the case? Is it pretty clear?
There's definitely like the technician variability. When we trained everyone, we tried to kind of emphasize doing it like the same way, like looking at particular depth that we're using and then using particular points, because I think the variability is more in location of the scan versus like the actual user. So just making sure that we're adhering to those 3 points is kind of the big thing. And then of course, there's always variability in how we interpret that. So that's why we try to use consensus with blinding. So yeah.
All right, thank you very much.
Before we move on, I just wanted to really quickly, on behalf of my class, give a big thank you to Dr. LeConte, to Crystal, to Jessica, and the entire research team. We really couldn't have done this whole day without you, and you've helped to nurture our passion for science and research along the way, and we just are so appreciative of you. So thank you all.
Are Crystal and Jessica here? Could you come down? You all have done so much work to wrangle us for 4 years, and we really appreciate you so much. We can't thank you enough for getting us here to this day. Thank you, Crystal.
Okay, we're gonna get Jessica because she's right now tallying poster award winners, so she's doing her work. Woo! Yeah.
Thank you, Jessica.
Very nice. Thank you, everybody. That was very kind. If we could have all of our letter of distinction speakers today come down to the front, we can acknowledge them one more time and get a picture of them with the plaque. That would be great. And then don't go too far because we have our poster winners from today voted on by both faculty and students, and we want to make sure that we get to award those in a minute. Hang on. Okay, so you guys have all seen these plaques on the wall. So who's gonna hold it? Somebody's gotta hold it. So, all right, there we go. Thank you. You all did a fabulous job. All right, so we're in the process of putting together our poster award. So while we're putting those together, I'm gonna say some thank yous real quick. So our mentors are amazing. So many of you showed up and supported our students, and I hope that all of you hear how valuable you are to all of this process. So thank you so much. The Center for Biostatistics and Health Data Science, the team led by Alex Hanlon, and you've heard from Dr. Monica Ahrens, Dr. Alicia Lozano, a great team that supports our students. So if we could all give a hand to that team. I always want to thank Dr. Nikki Worthington for all of the support that she's done. She's helping so many of our M1s and M2s begin this process. So if we could all give a round of applause to Dr. Worthington. Kara Spivey is up in the back. She's been mentioned many, many times. She's effectively a co-mentor for everybody who works on a Carillion-based project. So Kara, thank you so much. You're an amazing member of the team. Please make sure you're looking at all of our communications staff's work. So Josh Meyer, Catherine Doss, and Ryan Anderson are doing a great job of featuring all of the work that all of our students are doing. So thank you. Michael Long is sitting over here and has been so patient as we have scrambled all week to figure out how to put this together just right and made changes, and he's responded and been here and supported all of us. So thank you very much, Michael. I have to thank Jessica for putting together the survey, the QR codes, tallying everything, and putting her under pressure at the last minute to pull this off. So thanks, Jessica, for the survey help. And I do want to acknowledge and thank the support of our leadership team here at the School of Medicine. So Dean Learman, Dr. Friedlander, in terms of making this a core piece of our School of Medicine. So thanks to Dr. Learman, Dr. Gonzalo, Dr. Friedlander for making sure this is a part of our school. So thank you. I haven't said Crystal's name yet. So thank you, Crystal, for doing everything. Crystal keeps me sane and keeps all of you sane. So she runs all of this so beautifully. So thank you, Crystal. All right. Do we have awards ready yet? Yes, we do. Okay. We're going to do faculty awards first. No, it's okay. We'll do whatever you have first. So faculty were voting throughout the poster presentation session on 3 different categories. So we had 3 categories, and the first category, it's going to be a surprise to me, is the student who was considered the best poster presenter, who articulated their poster presentation with the utmost clarity. And so that award goes to Celine Marlin Andrews. Come down, come down. The next faculty award was for best hypothesis-driven study design. So student whose project best formulated a clear research question based on hypothesis. And that award goes to Jesse Bendetson. And our last one is outstanding scientist physician. So a student who best integrates clinical medicine with scientific inquiry and research, bridging the gap between discoveries and direct patient care. And that award goes to Kelly Ingram. All right, so now for the awards that were voted on by all of our students. Let's see what we have first. So for the student who had the most promising preliminary data for an NIH grant, that would be Abi Butada. All right, most likely to change clinical practice this year, Megan Knapp. Poster with the best visual design, Danny Purcell. All right, two more. Most hurdles overcome, Christina Gueco. And there's so many of you who could have received this award. I know this, but. All right, and most exciting discovery, Melissa Leaf. All right, that wraps it up. Be sure to pick up your posters. There's a few of you who are going to ask to not pick them up, but we'll catch you. And then scan the QR codes either at the top or the bottom for attendance. Thank you, everybody. Wait, what?
It's leftover food in the student lounge.
All right, I have not grabbed any of. We need Danny and Megan's there. Danny's there. Martin's right there on the way out.